And then my friend was telling me where she works as a nurse. On getting to UK, they gave her free accommodation of 3 months, free feeding of 1 month, and her work is about 18 pounds per hour. Let's be realistic. Some of us were trained by the community. Some of us were trained by our poor mother alone. Is there no recompense for this suffering? When is it about to end? There are people that, not everybody that have this kind of heart that we have want to stay here. I am a PhD student right now in public health. That's because I knew where I wanted to be. I knew what I wanted to do since. But guys, don't get me wrong. The picture is getting more bleak every day. So that if at the end of the day, the brain drain is annoying me, but I want to be part of it. Why?
You want to be part of the brain drain?
Yes.
Okay.
Except geography is going to change my mind today, or this panel is going to change my mind today. Because at the end of the day, this system is going to sponsor this. No matter how you look at it, our school fees is still cheap. I'm paying about 134,000 now, which was just recently increased for PhD. You cannot do PhD less than 4 million per session in Sena clients, yeah? So at the end of the day, I'm going to carry my pure service after attending my PhD and go and give to them. My professional, everything I've gathered professionally, everything I've done that Nigeria has helped me acquire, I'll now take it to go and work for them. But this is a sad reality.
Okay, thank you very much, Brian. And I was really touched by your narration. And when I did the mathematics, in fact, my phone was shaking, because if I calculate some people's salary per hour, I don't think they can buy one. So people don't earn up to 4,000 naira in a day. But I can see that your reasons are collaborating with that of MLS students. They're reporting around salary, and you also added the issue of support in research and grant. We are coming to that. I have some other things I've stated here. And the bank, before you go ahead, I know that you are a very, very pragmatic and very wonderful young man. I don't know why you're still in Nigeria, because your brain, I don't know. Please, what do you have to say about brain drain? Just in a few seconds, or few minutes, sorry. Then I'll ask you my next question, because I've put down some things here that we're going to address squarely. Because me, I was thinking that when I come here, I will have like some of my panelists against brain drain and some for. But I don't know, maybe after he speaks and the two other panelists speak, I will now know if you're only one-sided here. Then we will now know how to progress. So the bank can go ahead.
Hello, good day everyone. The issue of brain drain is one that cannot be overemphasized. We all know why people leave the country, and we know that people would always migrate when the conditions are not favorable. Right now in Nigeria, I believe the conditions are not favorable. Are they? All right, so I know of some medical facilities and hospitals in Lagos that pay scientists up to 250, 300, 400, 500,000. But is that still enough compared to living in Lagos? I think that it's not. And even if those facilities are, some of them are ISO accredited, but I think that the standard of living in Lagos is really high. I remember there was a time I was offered a job in Lagos, and then when I asked them how much they were going to pay me, I heard the amount. I said, no, I cannot stay in Lagos with that kind of salary, right? So I prefer I am where I am, then I manage where I am. So there are a lot of things, like other panelists have said, that are really the causative agent of brain drain. Now, we are high-profile professionals. We are well-trained. I know that Made really drilled me when I was in Unica. So a lot of them, we acquired quality skills. But then, when we acquire quality skills, our country avails us this opportunity. We are supposed to give back to the country. But we have come out in a society where instead of us being able to give out to the society is draining us. We are overwhelmed by the hardship in the society that we are now seeking for better options. So as humans, we are created to actually explore and then actually get the best life. So I believe that when there is quality, there is a sense of stability. So we want to be where there is quality, where there is a comfortable life, and then we want to have that financial security, and we want to improve in our career, as one of our previous panelists have said. But when we do not see this requirement, I know a lot of young MLS contact me, trying to ask me with the way forward, what they are about to finish service, and they're just scared if they are going to get a job. So you can imagine this. So once, if at this time, if I tell that person that, oh, you could gather your NYSC or internship money and actually get a registration in Australia, or get a registration in Ireland, and then migrate to Ireland. That is brain drain. Once the person migrates, that person has contributed to brain drain. I currently have someone who just finished internship, and the person is about to go for NYSC. And the person have already gathered HCPC documents. Is about to send send those documents to HCPC. So he get registered. Now he's asking me, what are the best approach? How is he going to do interview? How is he going to get a job soon after service? So that guy is not even ready to stay here one day after service, right? So this is what we call brain drain. It takes a lot to train somebody, but then someone is just out there to receive you and pay you money. You're providing services, is pay you money for what he did not train. All right, so that is it. It is Nigeria that is running at a loss. So brain drain is actually expensive for the country that is affected, and is actually less expensive for the country that's the recipient. So Nigeria is suffering. So the more we migrate, the more Nigeria suffers. Like she had said earlier, I think, I don't know if she was the one that made the statistics of the number of doctors per. So currently now, the number of doctors per 10,000 is 0.4. You can check that in Global Health Index. 0.4 doctors per 1,000. It's not sustainable. It's crazy. Number of nurses per 1,000, 1.5. Now, why won't people migrate? I was checking some statistics yesterday or day before yesterday. I saw that South Africa and United Kingdom share the same index in laboratory service delivery. That was crazy. So if I am a medical laboratory scientist and I am resident in South Africa, I wouldn't even want to go to the United Kingdom because they share the same index, number 1 in the world. UK and South Africa, you can look at this. They share the same index, 195. So, do you know the number, Nigeria? Do you know the number? Can I say the number? 106. Laboratory service index, 106. So why won't I feel like I should even go to South Africa instead of going to the UK? All right, because I feel like, these people are Africans, can better adapt. So these are the things that are actually contributing to brain drain. And then I hope that we'll be able to help our country by, even though we cannot stop us from going to the United Kingdom, Australia, and other countries to seek for greener pasture, career progression, and the rest of it, we can actually go there, acquire whatever we can acquire, and also contribute to our how do you call it, foreign exchange. All right, you go there and work and send the money to Nigeria. So instead of you doing your investment abroad, you can have a market in Nigeria. So that way, instead of only contributing to brain drain, you're also contributing to national development, right? So I believe that these are the ways we can exchange brain drain also for national development. And I also think that I know when they talk about brain drain, most people concentrate and dwell on nurses and doctors. And let me shock you. Just last week alone, I know about 10 medical laboratory scientists that got a job in the UK. And I know about 2 that got jobs in Scotland. Scotland is a part of UK. So a lot of Nigerians are getting jobs in Ireland. And then I have a lot that are getting jobs in, just last week alone, I know at least 12 to 13 medical laboratory scientists who got job abroad. These are people that are on the verge of leaving. All right, so imagine it. So it's not really it. So, but then if we go for greener pastures, let us contribute back to our country by finding a way to invest, by finding a way to collaborate. And then you want to know whether I want to leave as well.
And I think from your statement, I already know the answer. I do want to hear it from him directly. So okay. Let me not bring out another word from you. Thank you very much. I don't know if 2 other panelists are already online. Please, when they're online, signify me. But if not, we have 2 more discussions. First is bringing out why the major issues that is causing brain drain, and 2, the way forward. Because you just mentioned one of the way forwards, which is even though we go out, we have to also bring back, because importing back or exporting back and the resources you made there and investing in Nigeria is also a good one to the Nigerian system. But before we go further, there are some issues we need to address, because if these issues are addressed, people will not have reasons to be going out in droves, because definitely people will migrate. Migration, the way the world is now, is really a global village. People can easily travel today to UK and come back the next day. People can travel to Australia as far as and come back maybe in 2 or 3 days time. You know, people can travel to United States of America and still return in less than 2 or 3 days. So, but what are these major issues that are making professionals, health workers, most especially medical laboratory scientists, to move? What can be done so that even though people are moving, they are moving for the right reasons? What are these things? What are these health indices that have shown that people are not happy with the system? So that we now discuss what can be done. So from our discussions, I've seen that one of the major reasons that I've stated here is, number 1 is salary and staff welfare. Salary and staff welfare is very, very abysmally low. I can say generally low in Nigeria. Even those that pay you a bit too high, they want to take your whole life from the work, and you are stressed out. You don't have your time. So I think the next question will be, how can we have identified these problems? If you have more, what is the way forward? What is your advice? And what do you think we as professionals can do in that regard? And what the government and other stakeholders can do? So one of the issues that I raise is, 1 is salary and welfare. 2 is quackery. Because where they were supposed to employ 2 medical lab scientists or 5 medical lab scientists, they will employ 1 and employ people that are not qualified. Number 3 or number 4 is regulation. The regulatory bodies in Nigeria, I think, is abysmally poor. I'm not pointing figures and just Medical Laboratory Science Council of Nigeria, but most of the medical practitioners or medical councils, the regulation, because for example in UK, they cannot employ you as a medical lab scientist if you are not registered with HCPC. Even though you have practiced for 50 years in Nigeria and you are going to UK, you must be registered, and they will make sure that you meet the criteria. But in Nigeria, how are they ensuring that people that are practicing are well regulated and they are the right people that are being employed in different fields? I can shock you, even federal institutions, they even employ quacks that are not supposed to be, for example, in the laboratory. They employ them in place of laboratory because of cheap labor. So I think one of the issues we have is regulation. Another thing that was raised is career progression. The career progression in Nigerian system is very, very poor. Because so many people, you will be, for example, they don't even, for example, in federal government institutions, for example, in Nigeria, you don't progress in your career because of how good you are. You progress based on your years of practice. So you must wait for 3 years to be promoted, while you are doing well in the space of 1 year. For me, is it international best practice? I think that is what our panelists is going to, I would like them to address. These are some of the concerns. So in aspect of research, there is no good research that can be sponsored by an individual. You don't expect a sound PhD to come from, in molecular diagnosis, to come from a single individual. That is what the United States, the UK are doing. The government sponsors, so the sponsorship of research, I'll start from you. The government's sponsorship of research by scientists is very poor. People are ready to research, but they cannot. So these are some of the issues I've outlined from my research and your responses here. And I think we need to state it. How can these things be addressed? Because if it is addressed, I'm sure so many people will remain in Nigeria. But there's no place like home. I can tell you, no place like home. I feel more at home even when I go to my village than when I'm in Port Harcourt. For example, I'm based in Port Harcourt. I feel more at home when I go to my hometown. The same way, when you're in Nigeria, you definitely feel more at home. Because anywhere you go, there's a second-class citizen. That is why I try my best. In the past 5 years, I've practiced at medical lab. I'm looking at ways to get opportunities. So we're going to talk more. But I think let me allow my speakers to just use 1 minute, elucidate on these challenges that I've stated, and maybe speak on the way forward, what they think should be done. And if they have more reasons they think people, or more reasons they can state. But I think the major concern is for me, from the ones I've pointed out, what do you think the government or stakeholders or we can do to make sure that that our members, they remain in Nigeria to develop Nigeria? Because definitely people that will develop Nigeria are Nigerians, and people will import into Nigeria, not people will export. So, Tipang, let me start from you.
All right, thank you very much. So for every system to work, we know there must be control. All right, so a system cannot work when there is no control. And then where there are people, where you need HR, human resource people to work with you, it means that you must set regulations. So these regulations that are set are actually controls. Because if you don't set these regulations, system will be destroyed. Okay, so now I will start from home before I bring it to the broad, I bring it out wider. Now, in our profession, medical laboratory science, do we think the regulations are enough? For me, I think that the regulations are not enough. So if actually the managers of medical laboratory science are listening to me right now, I will tell them to look at their regulatory platform. Because who does that? You employ an MLS without being able to verify their registration status? And then you think we are employing is MLS? We start from there. So I am one person who was advocating for MLS to restore the online register platform, because it is not just about having the money, but it is about ensuring that you have enough medical laboratory scientists who are able to pay for their licenses. You make more money when you have a lot of these people paying for their licenses than only depending for these people that are going out to pay you some kind of money for them to be verified or maybe have a letter of good standing or thereabout. So then, because we have a lot of employers here in Nigeria that are actually employing medical laboratory scientists, but you do not even know that these people exist. In my chat, and I am also aware that I have a lot of medical laboratory scientists I know that do not even know where council website is for remitter payment. But every day, every month, they receive salary. So we need to actually strengthen our regulatory system and ensure that the right people are employed first, and then these right people contribute back to the profession. Then in the broader sphere, our government too need to be responsible, right? The government and the management of the country need to be responsible. So we need to have a lot of budget coming to health, a lot of budget going to education, and then we need to have this system that encourage our people to actually stay here, research here, work here, invest here, and develop here. Thank you very much.
Thank you very much. I think I'll give it to the mic.
Just in 1 minute, let's have your thought. You have addressed the issue of regulation. So maybe the other areas I mentioned, you can also address. Let's find solutions so that we'll have responses from the audience and contribution from those online.
Okay, firstly, I would like to mention that one of the core issues we have is implementation. About this regulation, we have ideas. We've talked about this. We've explored different options. But at the end of the day, nothing is done about it. So I think it's high time the council really sat up to make sure that some of these things are implemented. Also, you mentioned something, and I would like to use India as an example because they were listed as one of the countries suffering from brain drain. But today, it has all changed, and they are one of the countries having a brain gain. They have been able to get their people back in their countries. They have more skilled professionals, and they are making use of their experiences. And this is what they did. At some point, when there was a downturn and they were facing brain drain, they had to bring up different policies to make the environment enabling. And they even introduced interest-free loans for medical practitioners. And the usefulness of the loan was for them to set up different establishments or facilities in line with their dreams. Right now, they are even making a lot of money too out of medical tourism. So as it concerns brain drain in Nigeria, I believe we all have a role to play. First, in making the environment enabling, and also the government too has a major role to play in this. As scientists, we are also encouraged to be actively involved in politics. Those are the places where certain policies that affect us directly will be made. While we hope that someday the government will decide to be responsible, we also at our various levels need to take this thing by the hand and do what we have to do to ensure that the environment is conducive for us to practice. There was another point you mentioned too. You said something about the salary. Yes. It affects both the government and even private sectors. There are some medlab scientists here that run some private laboratories. They are trained professionals. You have access to them, but you do not want to pay them. As a professional, it's totally absurd. Let us try as much as we can to engage the people we know that are licensed and well equipped to serve in these capacities and pay them as appropriate. This will help encourage professionals to stay back. And before I hand over the mic, we are fastly approaching an election period. Let us not sit down and expect changes in our professions. We will live here and hear that 20 scientists that attended this conference have moved to another country in a space of 1 week or two. Let us take our voters card, be responsible, carry out our civic rights as appropriate, go out obediently and do the needful. Let's not just sit down and hope that the people there will make the changes.
Thank you very much. I think you deserve a round of applause. I want to be direct with you, Dr. Brian in view. You know why I say so is that I want to go to the area of career progression and research sponsorship. What do you think that will encourage medical lab scientists to remain in Nigeria, to research and also ensure that they grow in their career? What can be done to encourage that?
Thank you very much. I think Dibang and Prudence have spoken a lot, even if they were not as direct as I will be now. On this topic, I mean. So, it's high time as medical labs. I presented a seminar on Wednesday before I came down here. And I told my colleagues, my senior colleagues and my junior colleagues, I said, look, whether you like it or not, medical lab scientists have to go into, and not only go into, we need to love research. Okay, I was telling them in my hospital, we don't have an apheretic machine because that's costly, very costly. So by the time the MD will take care of a lot of things and then come and answer you for apheresis machine, that will be a long time. But do you know, with research, good research, like we don't need to do much with respect to all the our doctors that are here in the house. Systematic review from time to time. Like my hospital, if I decide to today lead a publication on clozapine therapy and its involvement with leukocyte counts, even if the study is there everywhere, it's not there in Federal Neuropsychiatric Hospital. So if we do a peer review and present our publication out there, and then maybe some other thing, there are a lot of things to research on. Do you understand me? And then if eventually 3 years from now, because we've not even started it at all, and 3 years from now, we go to apply for grants, for example, for these people to even take us serious, they want to see our contribution to the body of knowledge. And these things, please, I know Joe Great said something that no good research can be done by one person. Of course, he has a point. But we can always contribute. Like now in my program, the program I'm doing, I need to publish at least minimum of 3 works before my second semester finishes. I can't do it alone. So what they did is, we are 5 in my class. I will lead. Others will follow. In their own publication, they will lead. I will follow. So at the end of the day, you will see that my name is in about 15 publications by the time I finish my PhD.
That's a good one.
We have to, medical lab scientists we have to look beyond the bench. This is where the style is. And then I want to let us know something. Say, when you say there is animosity in intra-health sector or whatever we call it, it hasn't gotten to the place of research. Because if a doctor realizes, a medical doctor in this case, realizes that his findings has to do with a medical lab scientist or a nurse, and then he finds out that those people are good in that research, he will come and meet you. You guys will publish your work or whatever findings people are going to have. So at that level of research, there's nothing like all this animosity that we brand here.
Brian,
so yes.
I think I agree with you, but before you progress, because we don't have time, there's a statement that I also want to add. Maybe you make a comment so that I'll give for 1 or 2 responses. You know, research is a brain work, and it's only somebody that is mentally stable by the state of when you see your salary and your mind is calm, and when you know that you in the night you have meal, and in the morning you wake up you have breakfast, that will be coordinated to do a systematic review. Don't you think that the welfare remuneration and the state of payment of mental absence affects them doing all this research. Don't you think that we need to solve the primary issues, the basic needs of man, before they can think of research? Don't you think that is one of the major issues that is affecting us here doing research?
Thank you, Joe. Great.
So
Let me just put it in. Let me just finish it. Now the truth is this. If you listen to Professor Usse's lecture yesterday, if you go and read we have a lot of policies. We have a lot of policies that today medical lab scientists will not even suffer. We have a lot of, but there is no implementation. So it's not about whether you eat or not. Nobody bought the jam form for you. The truth is this: we have to move forward. We have to do other things. If not, we will sit down here and continue eating ourselves and blaming ourselves for one condition or the other. Meanwhile, other people are moving ahead. Do you get? Other professions are moving ahead. So we are not going to sit down here and continue the blame game. I am a part of the system. I'm suffering. But what do? We need to move ahead. Thank you.
Thank you very much. Thank you very much. Please, we are rounding up. Actually, I was thinking that this session is for 1 hour, but you say it's 25 minutes, so we are about rounding up. But before they say their final words and round up with this discussion, I need 2 persons in the house to either comment, ask question, or if you have something to say, just 30 seconds. Just go straight to the point. Then if you have anybody online, they can raise up their hand. Then you project them. They ask their question. Let them just raise up their hand. I just need 2 responses from the hall and 2 responses from those online, so that you can ask the panelists questions or you make a comment, we will respond. So 30 seconds means in 2 minutes we should be done with this comment session and question. So please, if you can just raise up your hand. Okay, 1, 2. Okay, please give this beautiful lady down there. Please go straight to the point.
My question is, what opportunities are available for laboratory scientists aside from working on the bench and lecturing?
Is it here in Nigeria or abroad?
In Nigeria.
Okay, in Nigeria. You are a very patriotic citizen. Okay, so I think no, give this person. I will give chance to that last person. Yes, give this person. Please go straight to the point. Please, I hope you are noting the question. Okay.
Okay. What I have is a contribution to the solution of Ben. So my contribution is, since the onus is on funding, is it possible that the body, because there is an Igbo adage that says, if they refuse you, if they reject you, you shouldn't reject yourself. So if is it possible that we can champion a campaign to to talk to these bodies that give grant? Because what I notice in grant giving is that there are interest. That's why sometimes when you apply for grant for a given business endeavor, you might not be able to get it because there is a particular interest or focus in that grant that you will not be captured in. So yes, for a certainty, you need to do something. There needs to be an established business for someone to give you a grant. But there are some that can be given based on the schedule, the outline that you gave the person. So is it possible as a body, can we be able to champion this cause, to meet these facilitators that give grants to institutions, to entrepreneurs, to be able to create a forum whereby young scientists who have enterprising skills or knowledge can be able to be given this grant to be able to fulfill their dreams and research? Because this is the critical problem we have in Nigeria. We lack funding from the non-governmental organization, from different institutions, because that is not part of their interest. So if it is possible, we can be able to champion this cause, so that if this facility is being created, it can now be possible that if you have an idea or a way to expand your business model, they can be able to access the grant.
I understand your question. Thank you very much, MLS Ajulu. You mean that, the last person here, you mean that for people to stay in Nigeria, there need to be opportunities, and can we as a body have an enterprise and go to the banks, get funds, and start this enterprise in order to encourage people to do business in Nigeria, right? Is that what you asked? Which course?
I'm talking about there are institutions that give grants for business people,
Yes.
for those who create business ideas. We call them venture capitalists. Is it possible for we as a body to meet them, to be able to create a forum whereby they can invest in these ideas, in medical ideas in Nigeria? Because that is not the case.
That they will invest in businesses, Abi?
I'm talking about investing in medical ideas, laboratory ideas. That is, we have ideas in terms of research, in terms
Okay, you are thinking about funding research.
of funding research, funding laboratories to be able to create employment
Okay,
opportunities.
thank you very much. I get you now. Thank you. So the last person here.
Thank you so much, the
Okay.
panelists. Please, my first point is just an observation. I did hear MLS Prudence. She did mention, she said she defined brain drain as a process. Considering the state of our nation and considering the circumstances behind this discourse, are we actually considering brain drain as a process or a state or a condition? So that is my first observation. My second
Okay.
observation is this.
I didn't get you. You said
Okay, MLS program Prudence did define brain drain as a process. But considering the state of our nation and also what we are discussing today, are we looking at brain drain as a process or a state, a condition?
Okay.
All right,
Okay,
so my
okay.
second observation is this. I did hear the three panelists, perhaps only MLS Pacelli, he actually quoted differently. I did hear the three panelists, okay, they actually quoted enemy statistics and the rest. Is there no publication by MLSCN about, because if all our quotation, all our citation is just reference to enemy, is there no work done by the MLSCN, because it's very needful for us to know. Thank you. That's my observation and question. Thank you so much.
Okay, thank you very much. I think we are going to respond to these particular questions. Then we have three persons online, so that we'll not waste time. First of all, Prudence, you can just shortly reply the ones you think, or the last question, right? About the definition. Whether brain drain, is it a process or is it
It's a state.
state? We are-
It's a situation. Nigeria is experiencing brain drain now. That's it, right?
For me, I think to also add that the brain drain is progressing. Because if 40,000 left last year, this year, it is not going down. We have more. It's not even stagnant. Maybe we have 60,000 going out this year. You know, I think it's a process and also a state. We already have brain drain and it is a continuum. So I don't think it will even stop next year. Except something is done, like the solution we are preferring here. So you say something.
Okay, so I want to answer the question of the first speaker, the lady.
Yes, opportunities for medical lab
opportunities
scientists.
for medical lab scientists. This cannot be overemphasized. This profession, whether we like it or not, is unique. We have a whole lot of, we heard of public health laboratory yesterday. We have informatics. We have, that as medical lab scientists, I think we can, as a matter of fact, operate anywhere. We have a whole lot of things there are a whole lot of specialties that are coming now. It's not only bench. As a matter of fact, you cannot be doing one thing over time and expect a different result. So it's not about lecturing or bench work alone. If you are going to the field, like me, I'm a medical lab scientist, right? I did my master's with bias in health education and promotion. So I can go to places as a health educator. This is me finding myself there now. So for a lab scientist, the world is your oyster. Just find out and research where you can go to, but far be it from you that is only bench and lecturing.
Okay, so before Pachali also comes in, I also want to respond to that question. Very good response. That is why this program is organized. One of the bane of med lab scientists is mentorship. Because Sometimes you cannot identify some opportunities except you identify some persons that will lead you to those opportunities. Who I am today is courtesy of some persons. I've not said I've arrived, but I've met people, especially in YMLSF programs, that both virtually, in fact, I met, like this my friend, I met him virtually. And by coming to occasions like this, you meet people in different areas. So if you research and see opportunities, try to identify or ask questions of people that are already making waves there and attach yourself to them. If it's public health, find somebody in public health. That's why we also have our monthly webinar of different people that are specialists in different areas. After the program, you can reach out to them. We also have a mentorship program that is coming on in YMLSF, where we have a 5-day strategic plan. And part of it is that in the next 5 years, we want to mentor young medical lab scientists in different areas, so that in the next 5 years, we can have people that will take over, whether in Nigeria or anywhere they are, and come back and give back to Nigeria. Because, for example, if it's into equipment and reagents and consumable marketing and sales, we have people. Why can't we have people that will train people in that area to become that? We have application specialists, because automation is the way to go now. Why can't we have people that will train young professionals? For example, ISM, for example, where I work, they have a biomedical training school where MNSF can partner with such organizations to train young professionals in application specialists and so many areas, and go out there and find jobs where they can be proficient. Because you cannot work where you are not proficient. You're a medical lab scientist basically, but some specialized areas you need some specialized training and experience for you to be able to work in those areas. So identification of mentors is very important, and you are in the right place. So identify the right persons after the program and so on, and meet with them and talk. That's why we have speakers, professors. You can meet them, and they will mentor you in different areas where they are proficient. So sorry for taking much time, but I just needed to lay some foundation on that. So the bank can go ahead.
Thank you very much, the great and the other members of the team. So, what's that?
You didn't say her name.
No.
Okay, Offend.
Offend. Yeah. So sorry. I think I did not quote enemy anywhere. I actually quoted World Bank information, and then secondly, I quoted Global Health Index information. So the information I quoted, you can find it in those two websites. So then, but unfortunately for us, they do not have any data for BMS. So for MLSN, I do not quote MLSN. But then, like he is talking about research, you can contribute to the world of knowledge by helping to find out what a number of medical laboratory scientists per 1,000 in Nigeria, and then that would really help. Then for hello lady, sorry, I want to add to what they said, but then I want to point to directly other things apart from lecturing directly that you can do in Nigeria. So he mentioned public health. Okay, myself, I'm into public health. I have never worked in the standard normal laboratory. I just finished and then joined the public, right? So you can work in public health, and then public health is vast. Then there is also what they call health commodity logistics. So you can do logistics, you can be a logistician. Then, and also there are other things you can do, like he mentioned ISN, that deal with equipment. But then in the space of, I'm sure during our undergraduate we did something like medical electronics, medical physics, biomedical engineering can also be what you can explore. And I tell you, those people that repair Abbott machine, and most of those machines, they make a lot of money. So you can actually try to take a master's in biomedical engineering and then explore. You can make a lot of money here in Nigeria, right? Yeah, well done.
Thank you very much, the bank. Very, very, very correct contribution there. So please, we are rounding up, but I want to give opportunity to the two participants. The first person, please unmute Chidima Ezenduka SDK to ask her questions or make her contributions. Please make it brief. 30 seconds. Thank you.
Okay. Good morning. My name is Chidima, and Hello, can you hear me? Hello, can you hear me? Okay, like I said, I practice in Enugu, and first of all, I want to thank the YMLSF for this opportunity. The panelists have made very, very interesting and very, very apt suggestions, and and they've given a lot of insights to the issue of brain drain. But I would like to, and everybody has touched on quackery and professionalism in the profession. And I would also like to just say something with respect to professionalism and the absent and then instituting and ensuring total quality management systems are working wherever we are in the country. It's easy to sit down and say laboratories should institute QMS, and that's the only way you can ensure there is no quackery. But what exactly are we as medical laboratory scientists, we as young medical laboratory scientists, what exactly is our value to ensuring that QMS is maintained in our own space? I was listening to a business leader some time ago, and he said something that, that has stuck with me over time. He said, Nigeria can be better, but if we are waiting for the government to do something big, it's going to take a long time. So that it's better to create oases of excellence. So wherever you are, you decide that I'm going to do the right thing and the right time. Coincidentally, this public health lecture is happening when we are celebrating the quality health, quality control in healthcare week globally. And the theme for the year is quality conscience, doing the right things at the right time. So if we as medical laboratory scientists, if we as medical laboratory professionals, because I don't want to limit it to just scientists alone, I want to expand it to every role in the medical laboratory space. If we as medical laboratory professionals purpose within us that wherever we are, we need to understand the tenets of total quality management and be able to step in and create oases of excellence wherever we are, we will have less issues. And there's something I always keep saying when the issue of professional animosity comes in. I always tell people, nobody will come into your space and take from you what is already in your head. Professor Tatfeng spoke about it yesterday when he said, don't be a stranger in your own profession. Many, many innovative things keep happening on a daily basis. You don't have to wait until you go out there and learn it, or wait for your employer to teach you about it. You can go online, use YouTube. All of us, we have smart devices. You can go online. There are courses that you can do for just a token, and then you can learn about these things, and then you can implement it wherever you are. So that's my contribution to the conversation.
Thank you very much, MLS Chidima Ezenika. I know your laboratory is one of the labs that implement total quality.
Can't say my breast is big? Is it not because of that?
Hello, good morning, everybody. Can you hear me? I can't hear you from my end. Please confirm if you can hear me. I can't hear you, sorry. But anyway, Sha, if you can hear me, my name is Elvis Besson. By name, currently I'm practicing in Borno State.
So Elvis, we can hear you. Go ahead.
All right. Currently, I'm practicing in Borno State, Maiduguri to be precise. I want to really
How is
appreciate
Borno,
the
please? I hope
panelists.
the practice is optimum there.
Yeah, Borno is calm and good when it comes to the MLS practice.
Wonderful.
Respect of pay and in short, as a matter of fact, I'm really enjoying it this way as compared to what people are facing down the south and the east. I want to first
Don't worry, we are
appreciate.
negotiating to Borno very soon. Thank you. So go ahead.
Please come, you are all welcome. I want to really appreciate the panelists, especially MLS, Diban Pacheli, my own brother from the same village. He actually spoke very well. My own is more of an advice where young MLS should actually explore opportunities in the NGO settings. At least I have confirmed that we have a lot to do in the NGO settings. These guys need us. As a matter of fact, they make more use of biochemistries, microbiologists compared to the MLS. So they need us. They need us, please. If you see an advert anywhere, for me, Maiduguri is safe, calm and clear. Borno State is fine, calm and clear. If you see an advert, please always try to apply. You can diversify. We must not do bench work. Personally, I wouldn't even encourage any young male scientist to even do any bench work, personally, because of the experience I've gained in an NGO setting and lot more. So this is just my own advice over from my end. Thank you.
In 2001, I think 2001, the African Union, they met in Abuja and they declared that the budget of every country should have at least 15% of the budget going to health. But you can see that one of the major things we have stated here is the underfunding of the medical laboratories or the health sector. And part of this, especially the laboratory, because I can say many of our laboratories in the teaching hospitals are understaffed, underfunded, and under-equipped. In fact, I cannot say that there is up to 1% of laboratories in Nigeria that are fully automated, that total automation. So what do you think is our role as professionals in advocacy, in making sure that these things are put in place? Because this is one of the major reasons people travel. Let me give you a shocker. If I'm going to travel out of Nigeria, one of the reasons is to gain the vast knowledge in these developed countries. Because there are some machines I've seen that we have not seen in Nigeria. I've seen it online. But I want to work with it before I die as a medical lab scientist. That is the only reason. But if I see those machines in Nigeria, I promise you I will not leave. You will see your grades in the next 5-10 years in Nigeria. So please, what do you think is our role ensuring that these things are put in place, especially proper funding and so on that affects many of us living the country? So, and you also add your final words and your advice to young medical lab scientists on the issue of brain drain. Thank you.
Okay. Hello. Thank you very much. So, like I said before, you cannot be ranking 106 in terms of laboratory service provision detection on global health index, and then you are now tell us that you can handle laboratory emergency, disease outbreak, disease emergency. Means that you cannot. You only would need intervention. There are just a few countries that can handle this, and it's unfortunate Nigeria is not one of them. And I believe that for us to be able to handle disease effectively, our detection system have to be effective. We have to be among the top 10. So that way, it means that our laboratory workforce, that is human resource for laboratory service delivery, need to be top-notch. So it's not only for us to have baseline trained medical laboratory scientists or medical laboratory professional. We also need to have advanced trained medical laboratory professionals. As I had said earlier, education is very expensive, training is very expensive, so the government needs to improve on healthcare budget, and so that at the end of the day we'll be able to train our personnel. So you cannot bring equipment and have the equipment working for themselves. People have to handle those equipment. People have to maintain those equipment. There have to be a working system. So the government needs to be responsible. And then for us as medical laboratory scientists, we also need to be responsible. So we should be the street police for lab. So what do I mean street police for lab? So I see when people are very comfortable having biochemistry, microbiology, science lab technology working in their site, and then they say, oh, well, it's the management and all of it. Well, I am not comfortable, and I don't know who is listening to me. I'm not comfortable because I believe that they are not efficiently trained enough and qualified to actually do the job. So this job we are doing is one that requires licensing. So if you don't have the license, first and foremost, you're not qualified. So no matter who you know or who you don't know, you're not qualified for that job. So we need to be vocal enough and not to compromise standard for anything. So we need to be very responsible to standard, we need to be very responsible to quality, and we need to be very passionate about it and very direct. So once it's not it, it's not it. We cannot mix it. So we need to be that serious. So another thing I would say in terms of my closing remark, I am one person who believes in ideation. So ideation can be found anywhere. Ideas are what breeds innovation. Innovation are what breeds advancement. Advancement is what brings us to effective and quality service delivery. So I believe that if we are able to ideate, we would be able to produce the quality in the end that we deserve. And tomorrow, the issue of brain drain would be totally dealt with in Nigeria. But then, we cannot do that without regulations. We cannot do that without effective budgeting. And we cannot do that as professionals without being passionate and enthusiastic and then very responsible to our profession. Thank you very much.
Thank you very much, MLS Pachali. You have done justice to that. So the next person, we are rounding up. So after I will conclude and round up.
Thank you very much. On a parting note, my advice to young medical lab scientists, first of all, love yourself. Love your profession. If they have to take a raw statistics right now, they will ask all of you, how did you come into MLS? In our days, that time, 2003, when we came into MLS, then it was, I wanted to do medicine. But they gave us medical lab science. Now, nobody even gives you medical lab science again. So it shows that the profession is growing. Okay? We are not second fiddle to nobody. So you have to love yourself. And secondly, please, try to go for courses. Do courses. Do certifications. My friend used to tell me something. He said, Brian, let it not be heard that they needed somebody for something. And I'm like, oh, Brian, I wish you had it. So that thing scares me. That's why anytime, please, if you see courses, it might look stupid. One day it will help. For those of you that are doing your HCPCs or have your HCPC already, you know that there are some hospitals that you apply for. They will ask you about your CPD, like this one that we are doing here. You can now write on a lot of things that you've learned for the past 2 days. This is what we are doing. You need to do a lot in your advancement of knowledge. And the last but not the least, please learn to network. Learn to network. At least we know our boundaries. We are adults. Because there are sometimes you want to network with somebody else. Say, please, can you help me? And then it goes wrong. But you know your boundary. Because there are people that are out there to want to help you or mentor you, like Joe Great said. Thank you very much.
Thank you very much. Thank you.
Okay, just to add to what he has said, it is very, very important as young medical laboratory scientists that we stay relevant. And one way we can remain relevant is what he has said. Take courses, grow, upskill. Sometimes we complain we do not have the money to attend these trainings, but there are also a lot of trainings that are available to us for free. YMLS organizes one of such trainings every month. It's there, it's for free. You go there, you gain knowledge, you gain the necessary skills. That too is very, very important. And we should try as much as we can to get involved. Let's not get used to sitting at the back. It is not okay that we are comfortable with where we are or what we are doing. Let's try as much as possible to leave our comfort zone and get things done when necessary. Thank you.
Thank you very much. At this junction, I want to conclude with the following words. As you have it, my panelists, they are not for or against brain drain or migration. But most importantly, what value you have, where can it be useful? In Nigeria, you can still be useful by looking for the right opportunities, network with the right persons. And if opportunity comes and you think going out would be great and it's going to help you to bring back development in the country, back to the country, why not? You can go out, come back and invest here in Nigeria. And the notion that most of us have that you are going out, you are leaving Nigeria for good, that is not possible. No matter where you are, your home is your home. Whether you go out today, your family is still here. Your grandparents, your friends, your family, and so on. So I want to encourage all of us that have traveled out, let us be able to come back and add value to our system. Secondly, I want to also use opportunity by using the conclusions of my co-panelists here, that we encourage our regulatory body to help those practicing in Nigeria by making sure that the right persons are in the right places and they are paid the right money. So please help us, especially Medical Laboratories Council of Nigeria. Finally, we want to plead with the government that they should increase funding in the health sector in order to improve the facilities at our hospitals, in order to build good roads and build good facilities in the laboratories that will help we that are in Nigeria to remain in Nigeria and to be more useful. So with this, I want to thank YMLSF for the opportunity to be the panelist for this year's annual public health lecture. And we pray that we continue to go stronger and have better opportunities to be more useful to our country, Nigeria. Thank you very much.
Hands together for them again. Wonderful people. The lead panelist, MLS, they call him Joe Great. What's his full name? Do you know his full name? Do you know his full name? Oh, Doug. I greet you, sir. You've done well. Thank you very much. Also, Okara Prudence was part of the panelists. Thank you very much. We also had MLS Pachili Dibang. Wow. Was also a panelist. FHI 360 Uyo. Thank you, sir. And of course, we had MLS Brian Edet from Calabar. Your hands together for all these wonderful people. Your hands together, ladies and gentlemen. Thank you, thank you. I hope we learned one or two things from them. And of course, it is important that we upscale. And it's so important that we don't start to jackpa. Jackpa is not the answer. If you jackpa, from here go to Obodo Yibo, it's still the same thing. No? We still have hustlers there. We still have unemployment there. People still stay for road, for street. Oh. So it's very important. So let us do this and be wise about it. On this note, we would like to welcome one of us for a spoken word. If your hands are not busy, please together, let's celebrate the presence of MLS Roots for our spoken words. Let's clap for her, please. Your hands together. Make no clap, make no clap. Thank you very much.
Good day, everyone. Thanks to the President and the EXCOs for giving me the opportunity to do this spoken word. In the world beyond our world lies the tiny and powerful, invisible to the eyes, but its effect evident for all to see. Today we focus and see them through the microscopic lens. Beautiful creatures they are, but they cause cough, catarrh. They raise your temperature. You're sick. Why are you sick? It is the effect of the tiny and powerful. In our place, we call them the microorganisms. Sometimes stuff gets so serious, and the problem is with our biomolecules. Is it a protein problem or a lipid issue? Oh no, it is a sugar problem. We need to check. The concentration is directly proportional to the intensity of the color change. God forbid we have a glucose problem and we require insulin shots. Shouldn't we visit the vampires? LOL, they aren't the drinkers of blood. But with a little sample of your red fluid, they could tell you your family's history and forbid you from marrying the girl you love because it is a genotype mismatch. In this other case, the tissue is the issue. For where we perceive the smell of formalin and see the effect of hematoxylin and eosine, what are we talking about? Be it microbiology, hematology, chemical pathology, or histopathology, we are the same people. We are investigators. We are the oracles, the bedrock of modern medicine. This is medical laboratory science. Thank you very much.
You don't see I'm finished now. Mona clap hand for her now. Let's celebrate her once again. You know it's you. And you remember she asked the question, if it's only for teaching and what? And lecturing. Where it's follow now? Where MLS? Please your hands together once again for MLS Roots. Let's celebrate her now. Thank you very much. All right. On this note, we will kick into action. Remember, it is our annual public health lecture, and of course, it's hosted here in Akwa Ibom State. It's been a wonderful experience here. We've been having good time. I believe you have too. All right. Shortly, we shall be having our first lecture for today, and of course, that will be on a wonderful topic, which is success and pitfalls using tools, samples in laboratory diagnosis of tuberculosis. The success and pitfalls using tools, samples in the diagnosis of tuberculosis. And of course, our own father will be taking care of that. But before that, I would also like to recognize the presence of our second speaker. Please let's celebrate MLS Dennis Ekpo. Let's celebrate MLS Dennis Ekpo. You're welcome. All right. So please, to do justice to this wonderful topic, if your hands are not busy, let us welcome the presence of Dr. Aniakan Augusta Ayo, your hands together as she makes her way. Let's celebrate her, please. Let's celebrate her, please. By the way you're smiling, it seems you ate white soup as you were coming. Is it true? Oh, wonderful.
Thank you very much. Good morning, young professionals. I'm always very excited when I'm in the midst of young people. You know, my job. Okay. So, I've been told that it will be better if you can move to this side of the hall so that you can have a good view of the screen. Can you see from where you're seated? Please just take a step and come this way. So that we can see the screen together. So I was trying to say how very excited I've been since yesterday that I came into your midst. I'm very happy to be a part of this program. I thank the leadership of YMLSF for finding me worthy to be one of the speakers in this public health lecture. So, I pray that we will appreciate what we are trying to bring up, because public health, just like Prof defined yesterday, is a thing of concern to everyone. So, we want to see a better and healthier society. So anything that can improve public health is something that should concern all of us. I am asked to speak on the topic, success and pitfalls of using stool sample for laboratory diagnosis of tuberculosis. We all know what tuberculosis is. It has been a disease that has ravaged many. It is a long-standing disease. I think it's an ancestor, if you want to look at TB among the diseases. HIV, COVID, that are receiving so much attention are not even as old as TB. But TB is still a problem. It's still a problem in the global setting and in the local setting, especially Nigeria, where we don't have a government that values the health of her citizens. The health sector, as we heard yesterday, has always been relegated to the background when it comes to budgeting, funding. The health sector and the educational sector. These ones, year after year, take the back seats, while things that may not even benefit the majority of the citizens receive good amounts. So, let's see what we can say about this topic. First, we just want to lay a background so that we refresh our memories about tuberculosis and then look at the current state of the disease, the current situation with TB. I have an outline here. I'll try to follow that outline. And I'm told my time is not as long as indicated in the brochure, so I'll try to make it fast. So we'll look at the background, the significance of TB diagnosis, challenges in TB diagnosis, and then the topic, the stool as an alternative specimen for TB diagnosis. Then we'll look at the various methods and look at some studies that have been done using stool sample, what we can draw from that. and then highlight the pitfalls and the success, and we'll conclude with that. Okay, so background. We already know that TB is a communicable disease, and it's caused by Mycobacterium tuberculosis. It's usually a complex. Mycobacterium tuberculosis complex, a complex of organisms of the same strain that spreads from person to person. Is a respiratory tract infection, so that means that actions such as sneezing, coughing, especially when people are in a close setting, can transmit this disease. So if you're very close with a person who has the disease and the person coughs or sneezes and you don't have any means of protecting yourself, you can contract the infection. TB is a leading cause of death. Is the leading cause of death from a single infectious agent. You know, we have said it is caused by Mycobacterium tuberculosis. And from the latest reports, death from tuberculosis keeps rising. So it has claimed so many lives. Every year we hear millions and millions of deaths, both globally and locally. As in the Nigerian setting, we have many millions of deaths reported every year, including children. Children are not even left out of this mortality rate. And the latest WHO report, TB report of 2022, has said that TB, the death from TB, even outruns HIV, Ebola, and malaria. So the death from TB, the records are far higher than all these other infectious diseases. So we can see what we are dealing with. All right, next. This is a picture, a global picture of what TB is doing. And this is from the WHO TB report of 2022. So TB is more badly impacted than HIV. From that curve, the blue curve there shows TB deaths in HIV negative people. As people, we know that TB, when combined with HIV, is a very, very bad combination. But deaths from TB in people who are not also HIV positive is increasing. Look at that report is 2020. Then the latest 2021, we can see that the curve is going up again after we thought we were making progress, you know, success in reducing the infection. We are having an upward turn. Then the black curve shows death from HIV/AIDS alone. You can see consistently there is a downward trend. So that means death from HIV is reducing progressively. While TB deaths in HIV positive patients, those ones that have the two infections, co-infected individuals, is even declining faster because of the attention of this group of people. The focus on this group of people. Most preventive treatments are given to people living with HIV. Why? Because they have access to treatment. You know, because they have to go for their drugs always. When they go, all these other things are checked. And drugs, whatever interventions are given to them. So access to health has also helped the death in people living with HIV to reduce. Death from TB in HIV patients. All right, those numbers are in millions per year. So we are not talking of just 200 or 3. We are talking of millions, 240 millions, you know. So the deaths are very, very high. The incidence of TB and the incidence of mortality is high. Let's go on. That's the global picture. There are 30 countries that have been listed as high TB burden countries. And Nigeria, of course, has made that list. You know, we don't take last when it comes to bad statistics. Nigeria makes the list of the 30 high TB burden countries. And those 30 countries contributed 87% of TB cases in 2021. Those 30 countries. And out of those 30 countries, 8 of them, which Nigeria still made the list, contributed 68% of the global cases in 2021. So, where you see the blue circles, of course, Nigeria is prominent there. It has overtaken Nigeria anyway. The size of the circle indicates the burden. So, those are the 30 high TB burden countries. Let's go on. Yes, these are the 30 countries listed. And in this graph, we are comparing the cases in 2020, the reported number of people with newly diagnosed TB in 2020 and 2021. Wanted to see this from the WHO TB report of 2021 and of 2022, yes, comparing the last 2 years to see if there was a reduction. Now, Nigeria is the last one there. If the dots, the blue dots represent 2020 and the orange dots represents 2021, Nigeria is the last country here. Please look at it. Did we make any progress? Is there any reduction? This is 2020. And this is 2021. Is there any reduction? Instead, in fact, we surpassed every other country. See our value, our figure of new cases for 2021 is about 180 cases per 100,000. So we surpassed. We didn't even make any effort at all in reduction. But some other countries, where they were in 2021, they have gone backwards. So that means there was real reduction in the number of new cases. That shows where work is done. And of course, there are many factors that contribute to this. Sometimes, you know how our terrain is. The people that have these diseases cannot be reached. The surveillance officers cannot even reach those places where they are to find out if they have these cases or not. But we are hoping that with the new year, there will be some progress made. Data shown here for these 30 countries, and then there are those that have been, they escaped the 30 TB high burden countries in the last report. So they are placed on the watch list. Those countries are Cambodia, the Federation of Russia, and Zimbabwe. They are on the watch list. They had made some progress, but they are still being watched in case. So these are those countries. Let's go. What I want to point out is that Nigeria did not make any progress in terms of reduction in number of new cases. The cases are still increasing. So in Nigeria, for 2021, those new cases were attributable to 5 risk factors, namely malnourishment or undernourishment, HIV, diabetes, alcohol use, and smoking. If you look at those factors, you find out that it's mostly this, TB is a disease of poverty, because when you talk about undernourishment, it means there is no food. So many people that fall into those categories are people that are poor. Then lifestyle also plays a role. Lifestyle, when you talk of smoking and alcohol, that's a choice thing, unlike undernourishment. Then HIV and AIDS, of course, underlying conditions. There were a total of 204,725 new and relapsed cases in Nigeria in 2021. And children aged 0 to 14 years made 7% of that figure. The case fatality ratio for that year was 28%. Okay? Here, these are the risk factors. Undernourishment, the highest, HIV, of course, co-infection, diabetes, smoking, and alcohol. So that's just to show you how much these factors have contributed to the disease. TB incidence in Nigeria, that's the figure for the past 2 decades. The incidence has remained consistent. It has remained consistent at about 219 or 220,000. 219 or 220 per 100,000. And for that period, 2000 to year 2021, that's 20 years, 2 decades. You see that the number of new and relapsed cases keeps increasing. This is the Nigerian picture now. This is Nigeria, not global. The number of new cases keeps increasing every year, especially after the COVID, the post-COVID era. The incidence keeps going up. And then HIV positive TB, the HIV positive associated TB incidence is also falling, just like we saw in that global picture, because of the reasons I've already mentioned, that these people get a lot of attention, and because of the health-seeking behavior of these people. They have been so enlightened, they have been so educated that they know they have to go for their drugs. And when they go for their drugs, they get other interventions. So that's why this picture is consistent, both locally and globally. Now, this is the incidence of notified cases of TB in Nigeria by age group and sex. This compares the incidence in males and in female, and then the age groups that are impacted. From this, you can see that the age group 25 to 44 in both males and females are the ones that have been greatly impacted in the last year. For all the notified cases, that's the reported cases, diagnosed and reported cases of TB in Nigeria, were concentrated in that age group. Then you also see children 0 to 14 years are not left out. So children before now were taught, it was thought that children don't really come down with TB. But from the reported cases, we have seen that their own is also significant. The cases in children is increasing. Children are being affected because if they are in this environment that we have described as risk factors, then there's no way they will not be impacted. They are also humans. So if they are around people that are infected, they will be infected. For instance, in households, if there is an adult that has TB, and we know that it's an airborne disease, the children in that household will also contract the infection. So more cases of TB in children are now being reported. All right, let's see. The profile of TB in Nigeria for the year 2021, the population of Nigeria was estimated at 213 million. Yesterday, Prof was saying, some say 210, some say 220. So 213 is still beyond, within the range. Our population is increasing. These are estimates. So the burden now, if you look at those figures, the same picture is playing out. The picture we see globally is what we see locally. We still see that HIV-associated TB mortality is lowest, while HIV-negative people are mortality rate that is very high. Imagine 13 out of every 100,000 people, have 13 people coming down with TB. So it's very high. The mortality rate is very high. 53 per 100,000 population. That's the rate. And you have 112,000 people, dying in that year under consideration. 2021, we had that number. And the reason for the low mortality of TB positive cases is highlighted there. Most preventive treatments are given to them because of all the sponsorship, the support that this group of people have had. There seems to be so much concentration. Let's go. But just bringing out the facts so that we know what we are dealing with. And the pandemic has not helped. It continues to have damaging impacts on access to TB diagnosis. Remember, in 2021, everywhere was shut down. This also affected the healthcare delivery system, and the treatment too was impacted. If there is lockdown, people could not go out to access anything. So if there were cases within a community, it will continue to increase, because as long as they remain in that community, the transmission chain is open. And the progress that has been made before the year 2019, before the year of the COVID, that progress, the gains recorded have been reversed. From 2020, we now saw that everything was going back to the drawing board. Like the curve I showed before, the number of cases were increasing, number of new cases, the incidence, the mortality, everything is going up, trying to negate all the effort that has been done before 2019. And this calls for increased funding. We have to make meaningful progress, because we are now running against time. The target for the WHO target to end TB was set at 2020. We are 2 years past that year, and nothing, if at all, the efforts, the gains have been reversed. So we are off track. The need for action has become even more pressing in the context of all the things that are happening in the global scene. Nigeria is not left out. The flooding we are talking about in the country is a factor that can even bring more devastating effects when it has to do with TB. People are now in IDP camps, and those are environments that are very, very genuine for transmission. When people are packed in places, people you don't even know, you don't know the health history of that person, but you are cramped in together. So I think the results for next year will even be worse if nothing is done. But we pray that our government will do something. Let's see the next, okay, that's the funding. The national TB budget for 2022, we are still in 2022. So we are looking at how far we have gone since 2018. That's the budget. The budget is in millions of US dollars. The blue indicates domestic funding. That's the national funding. The yellow is international, counterpart funding from the international body, NGOs, all those institutions that give funds for this purpose. The IMF, the World Bank, and some foundations like Bill and Melinda Gates Foundation, the German government, they have contributed 24% of the total budget for TB in Nigeria. Then the Nigerian government has provided only 6.5%. The people that are affected have contributed 6.5%. The external bodies, 24%. While the rest of the budget, a whooping 70%, is unfunded. That means that the individuals, the patients, the ones suffering this will have to shoulder that responsibility. They have to take care of themselves, because what government has provided cannot go around. So the bulk of the money is borne by individuals, patients, and their families. All right. Yes. Next slide. So with this picture now, we have been told that a lot needs to be done because all the gains we made up to 2019 have been reversed. We have gone back to the drawing board. TB diagnosis has to be more aggressive because if you don't diagnose, you can't treat. You know, diagnosis is very important. So the significance is that early and accurate detection of TB is critical for timely initiation of treatment. But there is a widened gap between the number of people that are falling ill and the number of cases that have been reported. So there is a gap between the actual number that are infected and the number reported. So what can be done? The past 2 years have shown, this report is from the past 2 years. They've consistently noticed that the number of people that are infected are more than the number of cases reported. So reduced access to TB diagnosis suggests that number of people with undiagnosed disease grows, resulting in an increased number of TB deaths, and of course the transmission will also scale up. Next slide. Okay, that's the gap we are talking about. The gap between TB incidents and reported cases. This is a global picture. 10 countries accounted for 75% of unreported cases. That gap. 10 countries, and like we always do, Nigeria has made that list again. Nigeria is among the 10 countries that has actually not reported the correct figures for the actual situation. HIV negative TB mortality in Nigeria. In 2021, it dipped. That's for the Nigerian picture. It dipped a little. There was a little reduction. But from that curve, you see that there is not so much. The reduction for Nigeria is not so much. That's why we couldn't make a good impression at the global scene. Because what is shown there is still within range. That means we have been consistent from 2000 to 2021. 20 years, we have not made so much improvement. All right. Challenges in TB diagnosis. What are the challenges? We have been told that diagnosis is key to whatever progress that must be done concerning TB. But there are challenges in TB diagnosis. The diagnosis is particularly challenging in children. And we have seen that children are not left out when it comes to this disease. This disease does not discriminate. Every age group is impacted. But the diagnosis, which is key, is challenging in children, especially because of the non-specific clinical presentation. That's why it was erroneously thought before that children TB in children is not so much, and so the attention was paid to children. But it has been discovered that children are also affected. So because of the non-specific clinical presentation, difficulty in obtaining samples, and the postbacillary nature of the childhood TB, in children, the number of the organisms, it is very difficult to, detect because the number is usually very low. So that has also added to the lack of reporting the actual cases, because all these cases, because they are, the number of organisms seen is either not there or they are missed. But sometimes when that happens, clinical symptoms can also help to diagnose. But in children too, the clinical picture is not clear. So this has added to the difficulty in diagnosis in children. Sputum remains the most frequently used clinical specimen to confirm TB, especially when we talk of bacteriological confirmation. It is sputum that is used, and it has yielded good results. But because of that problem with children, different procedures have been employed to obtain sputum from them. Some of those procedures include induced sputum, where sputum has to be induced because they cannot expectorate freely or on demand. So it has to be induced. Bronchoalveolar lavage and gastric aspirate. The problem here is that these procedures are very painful, especially for that age group. These are not well tolerated in children, where you have to pass a gastric tube just to get sample. It's traumatizing for the children and even the parents. Imagine if you have a 3-year-old and that procedure is carried out in them. Watching can be very traumatizing. And such procedures also need trained staff, well-trained staff to carry it out. Not everybody can collect that kind of specimen. Then, when we see that TB is a disease of poverty, at least from the risk factor, we saw that malnutrition is one of the risk factors that had very high significance. It means that the setting where this disease is, you will not find such highly trained professionals to collect that kind of sample. Maybe they are in the rural areas where accessibility is even very poor. How do you find people and they can't have access? The roads are not there. They can't have access to come out to where the health facilities are. So it's difficult. And this makes diagnosis in children to be too late. Sometimes when it's very late and the intervention may not even work. Or not at all. They are missed completely, and so they continue to add to the mortality. So there is need for non-sputum based specimen to diagnose TB in children and other patients who are unable to produce sputum. And that's the crux of our lecture this morning. The rule of thumb is that patients diagnosed with TB using culture, the rapid molecular test. Professor Taffen made mention of molecular techniques, and sputum smear microscopy. Those diagnosed by these methods are defined as bacteriologically confirmed TB cases, because of course you're dealing with the organism. Whereas diagnosed in the absence of bacteriological confirmation are classified as clinically diagnosed, because here just the symptoms and maybe X-ray is what is used to diagnose. So there is no microbiology there. So these cases, the clinically diagnosed, are usually referred to as unconfirmed TB. But most times, because anti-TB treatment is initiated, and if they respond to that treatment, it means that actually they had TB. So that's just to differentiate that they are called unconfirmed TB because there's nothing to confirm. You didn't see the organism. But the other techniques that actually point to the organism are the bacteriologically confirmed. All right, next slide. So why is stool important as an alternative specimen for TB diagnosis? From all the reasons we have proffered, the reasons we've given for the non-diagnosis in children and others who may not be able to expectorate, stool has become very important as an alternative specimen. The introduction of GeneXpert and this was in 2011. GeneXpert is a real-time PCR. This completely changed the scene because here, so many other specimens apart from sputum could be used for diagnosis. Lymph node tissues and aspirate CSF, gastric lavage were all used because of the introduction of gene experts. So it changed the scenario. And in the past 10 years, there have been many studies trying to see the effectiveness of using stool sample for diagnosis, and they've come up with very good results, although there is a paucity of data from Nigeria. So that's an area for us to look more into. If we are using stool sample to do diagnosis, we have to give out the result. Just like Prof said, it has to be documented. Let's see what the situation is with Nigeria. Are we making, is there any good indication? Because if it's not recorded, it means it was not done. So when we document whatever we do, it gives us an idea. And those are the data that WHO uses for planning. All those data I reeled out, if there were no reports, we wouldn't have them. Okay, let's go. Now, why is stool sample a good alternative? Because, you know, for children, when they cough, the tendency is for them to swallow, isn't it? Children, when they cough, even when they swallow their sputum. So this sputum that is swallowed, you know, can be detected if there is TB mycobacterium there. It can be detected in stool. And stool can be obtained easily. It's a painless, it's just a natural process. Nobody has to pass tube to collect stool. So stool is obtained painlessly from infants, young children who are unable to produce sputum. And to even make it better, in 2018, a scientist called Petra de Haas of KNCV Foundation, the foundation is based in the Netherlands, she showed that stool can also be easily used as a specimen to detect TB with the same processes for sputum examination. So that's a win-win situation. Using bacteriologically confirmed TB on respiratory sample as a reference standard, the current diagnostic modality with all its limitations for stool sample has been achieved. Okay, next slide. That's a summary of specimens for pulmonary TB diagnosis. You have sputum there. That's, of course, that's the classical specimen. Induced sputum. Let's go. I'm just showing all the samples that can be used. Gastric aspirate, nasopharyngeal. But to collect this specimen, you can see the procedures are a bit uncomfortable. Lymph node, where fine needle aspirations are taken, a bit uncomfortable. Urine can also be used. The breath of the patient can be used. But our interest is stool. It is safe. It is non-invasive. The other specimens are, apart from sputum and urine and breath, the other specimens are, they require invasive procedures to obtain them. All right? Now, this is a summary of diagnostic tests for pulmonary TB. We have the optimized smear microscopy. Before now, microscopy was the gold standard, but we've moved along because of the introduction of these molecular techniques. Solid culture on Lowenstein-Jensen has also been useful, but the problem there is that it takes a long time to reach diagnosis, and it's a bit cumbersome, since to do that you need at least level 3 biosafety facilities to carry out culture of TB. Then the urinary lipoarabinomannan assay. This one, although it has a low sensitivity, but it is non-invasive, and it is very, very useful in immunocompromised adults, people with HIV. It's easy to use urine to diagnose those ones. Then we have the MG, the Bactet 9000. These are all automated liquid culture. String test, volatile organic compound test. This one identifies specific patterns of volatile organic compounds produced by MTB. So when that is observed, then all we need is to, the sensitivity may be low, but at least diagnosis for TB, once it is there, it is there. So you will know that that person has TB. So all these methods have found usefulness in TB diagnosis. All right? Let's see. Then the real-time PCR, where we're using our gene experts now, which also tests antimicrobial resistance, especially rifampicin resistance. So that one is a double-edged method. It detects TB and at the same time detects antimicrobial resistance, which in itself is a pandemic. Antimicrobial resistance is a very troublesome area now. All right? Please, next slide. Okay, there are other molecular methods, like the nucleic acid amplification assay, so many of them. Okay, now, the method for gene experts we have for the respiratory sputum, the respiratory specimen. That's the procedure, depending on which one, whether it's expectorated sputum or induced or gastric aspirate. Whatever the sample, it goes through this process where it is diluted with the reagent. I'm sure most of you have gene experts in your facilities. You know the procedure. So the liquefied specimen is aspirated using sterile pipettes and then uploaded on the gene expert instrument, and the test is run. It has really simplified diagnosis. The culture method also, where you can use your Lowenstein-Jensen for the solid culture or the liquid culture. I mentioned MGIT. So that's also the procedure. I'm trying to rush now. But for culture, there is that process of decontamination, that's liquefaction and decontamination. So that makes it tends to elongate the process. That's why culture, the only setback with culture is that the time taken to reach diagnosis is very long. But it's a very good method because if the organism is there, you will find it. All right. Please, can we have the next slide? Now, for stool, remember we are trying to see how useful stool is. For stool, the gene expert procedure follows the same protocol with the respiratory specimen. But the KNCV TB Foundation has brought a simplified method such that you don't have to go through all that process of liquefaction and decontamination. So that tends to reduce the time. So for that procedure, 1 gram of the stool is transferred and 8 ml of the sample reagent is mixed with it. And then those 2 steps are, what do I say? Those 2 steps of liquefaction and decontamination are bypassed. So you move straight to using the supernatant to load in your gene expert cartridge using a sterile pipette, and then the test is run. So that process is, the time for the process is reduced, and the process, the test method is very sensitive because it gives comparable results as the sputum specimen. All right? Next slide. So there have been many studies that have compared these 2 samples, the respiratory sample and the stool sample. And their aim was to see the similarities between sputum and stool to obtain bacteriological confirmation of TB. And also to assess whether the gene expert testing of stool in children is possible with that 1 step, the KNCV method, and it was seen to be very okay. They also measured how laboratory staff accept the use of stool, because that is very important, the acceptability to use stool sample for the diagnosis of TB. It didn't come easy. So many people did not accept it. You know, they said it makes TB smell like like poop. Poo-poo. That's what they call it. They say it makes TB smell like poop. So it wasn't easily acceptable. But from the results, let's see the next slide. From the results, it is shown that stool is a very good alternative specimen. In Ethiopia, they had very good results. The sensitivity of the stool experts was comparable to the GA culture, which was used as a gold standard. So out of 152 children, they were able to diagnose 20 of those children with TB, and the 10 of them had bacteriologically confirmed TB. That's positive expert and culture. And the remaining were clinically diagnosed with positive response to anti-TB. But the result that they got with culture was almost the same. In fact, the stool expert even detected cases that were missed by the GA, that's gastric aspirate sample. Let's see the next slide. Okay, that's the sensitivity. The sensitivity was 100%, and specificity 99.3. That's a very good one compared to culture. And the gastric aspirate, the sensitivity was even 77.8%, and specificity was 99.3 compared to the culture, which was used as a gold standard. So if you compare GA and the stool in that particular study, you find out that stool sample did better. Okay, let's see the next one. All right. This is the diagnostic performance of GA and stool. So that's just what is shown there on the table. Let's go. Another study which combined, that this was a meta-analysis, combined 9 different studies to see the sensitivity. 9 different studies that compared the performance of stool sample with respiratory sample. They pulled them together to see how the stool fell. And in this study, the pool sensitivity was 67%, and the sensitivity was 99%. So this showed that in some cases, of course, because of a range of factors, the stool sample did not do very well, but in some, it did very well. So they had a range between 32% and 85%. So you can see it's 85%. If somebody scores 85%, that's an A. So it's still good enough. All right, let's see the next one. So what are the successes of using stool sample? Having seen what we have the comparison between these two specimens. The prospect here is that stool is a non-invasive sample. It can be obtained easily and it's safe. You don't need to traumatize anybody to collect sample. It is safe. So, and stool experts can be performed by a simple tool testing protocol that has been put out there by KNC TB Foundation. So this protocol makes the time to diagnosis shorter, even shorter. So it's even more beneficial. It eliminates some of the cumbersome steps that you have to use with the other methods. So that's a plus. Stool experts is a good alternative in the limited capacity to implement specimen collection in children, which restricts the impact of the near point of care introduction of this particular technique. What I mean here is that expert was introduced because the other methods were not yielding fast results as required. Like stool, you have to wait for days to obtain results. But GeneXpert was introduced because it was going to be a real-time thing. You know, PCR, real-time means that as you're doing, you're seeing the results. But with children, the difficulty in obtaining samples, so this was almost going to, you know, be a disadvantage in this good procedure that was introduced. Getting sample from them wasn't easy. So with the introduction of stool, they were able to attain that point of care, you know, diagnosis. So you could just get your stool and do the expert, and in a few minutes you get your results. So the aim of introduction of expert was achieved, especially with children with GeneXpert. Emerging evidence suggests that using larger specimen volumes and pre-treating with stool processing buffer, you know, to inactivate the inhibitors of PCR, achieve even greater diagnostic value. So, and it is only in stool that you can use more sample. Sputum from children, if you can even manage to get, it will be very small. So with stool, you can, the volume is not a problem. You can achieve that with stool. Repeat testing on stool is also possible, and that also increased the sensitivity from 44.4 to 70. The simplified method, like I mentioned, has also made stool very promising and to minimize delay. All right. So what are the pitfalls? From the results we just saw, where we had low sensitivity in some studies, is that poor performance of stool experts was reported in clinically diagnosed, and we have already explained what clinically diagnosed means. It means that the symptoms is what was used to diagnose those cases. So when stool expert was performed on those samples obtained from clinically diagnosed, the performance, the yield was small. And of course, it is because of paucibacillary nature of the disease in children. The major drawback of stool culture is the need for that stringent decontamination process, because you have to decontaminate to prevent overgrowth of the normal flora. And in the process of decontaminating, you can also remove the vital organisms that you're looking for. So the mycobacterium in the sample can also be removed, and that makes stool culture insensitive. So using stool for culture is not very sensitive, and that has become a pitfall for using stool sample, but with culture. And then the low acceptance of the process is also a pitfall, because not many laboratories have accepted the use of stool sample. All right, I'm ending now. So don't give me more paper. I'm done. So in conclusion, the sensitivity of stool expert is comparable to respiratory samples, and the specificity is very good, because in all the cases we showed, the stool samples detected all that even the GA missed, even the respiratory specimen missed. It was detected with stool. The major advantage of obtaining bacteriological confirmation is the ability to make a definitive diagnosis and to perform drug sensitivity, and that has been achieved with stool sample. In the era of increasing multi-drug resistance and extensive drug resistance, when it comes to TB, you have MDR, you have XDR. This information, that's the prompt diagnosis, becomes critical in order to guide appropriate therapy. Thank you very much for listening.
Hands together once again for her. Dr. Aniekan Augusta Ayo. Ma, you've done very well. Please let's celebrate. Keep clapping, keep clapping, keep clapping. Thank you. All right, at this point, we would entertain just 2 questions because of time constraints. 2 questions, if not even one. But because of time constraints, we'll take 2 questions. Please, if you have a questions around what she has said, please just indicate. The mic will be passed to you. And of course, she is here to answer your question. Any question? 1, I think, should be it. All right.
Thank you very much. Thank you very much. Thank you very much, madam, for this wonderful presentation. In fact, let me comment on this. As a matter of fact, this particular presentation has helped me a lot. Let me not go further. Myself, I think I'm the only person that understand what I meant by it has helped me a lot, because I'm actually working on this. But the question is this: yeah, you talked about children. In essence, you meant that using stool to diagnose for tuberculosis is more common in children. But I want to know, at what age group, at what particular age group should stool be used on children? Is it between zero to what particular age group?
When we say children, you know, we are classifying 0 to 14 as children. All right? The first age demarcation is 0 to 7. Because in this particular group, sometimes you can't ask them to expectorate. You can't ask them to bring out sputum. They don't even understand what you're saying. Because anything that comes up, they want to swallow. But for the older children, some of them can. So there is an overlap. We'll just say 0 to 14. These are children. Any of them in the upper group that cannot expectorate, then stool can be used for them. Okay? But particularly in infants and the younger children.
Your hands together. Thank you very much, Dr. Augusta. All right. And there's something worthy of note that I saw in I think in the chart that she had there. You said, I think it was around the risk factors. The number 1 risk factor, mine is what? Hunger. Hunger. So, please, the country is getting wonderful. Let us eat healthy, please. You also, anything can happen. With a cough anyhow. All right, on this note, please, we'll be having our second lecture. Remember, today we are supposed to be at the beach. So please, for our speakers, take notes. We are supposed to be at the beach today, and the time is fast spent. Most people don't gather their beach wear. I can see my friend Kema, he already has his beach cap. So please, we'll be fast on this. All right, please, if your hands are not busy, let's celebrate another erudite member of this wonderful profession. He'll be taking a topic: accurate laboratory diagnosis, pillar of quality health care. If your hands are not busy, please let's welcome, to do justice to this, MLS Dennis Ekpo. Your hands together for him as he comes to deliver his wonderful presentation. And also, I would like you to know that we also have one that I respect a lot. He will be our third speaker, Dr. Kemsi Elechi Amadi is in the house. Your hands together for Dr. Elechi Amadi, capacity doctor. I greet you, sir. All right. Are we ready, sir? All right. So, whilst they are taking care of the presentations and all those things required for a good view, I want to say, please, eat well, eat well. That one strike me. It is not everything that is witchcrafty. Eat well. Let us advise our family member, eat well. And they cough, dry cough, and they cough, eat well, eat well. It's the leading cause, risk factor, hunger. You know. And I got to learn that the most important meal for the day is what? Is what? I don't chop. I'll be on the way for conference. Eat well, you know. So the most important meal for the day is your breakfast. And doctor, breakfast to when?
Breakfast is not my most important meal for reasons, very cogent reason. Though it has been going on that breakfast is the most important meal of the day. But for me, I have learned that there are so many things that go on in our bodies that result in disease conditions. And one of them is cancer. So researchers have shown that cancer cells feed on carbohydrates, so, and sugar. So when you eat, the cancer cells are empowered. But if you can starve the cells, you find that those cells die naturally. They die off naturally. And there is no better fast than that overnight fast. And if you can miss your breakfast, that gives you, a longer time. And then you take your lunch early. Yes, take your lunch early. So that's what I can say. From 12. Yes, from 12, take your lunch early. Or you can take what they call brunch, the earlier one from 10.
If you take brunch, it means you are collapsing the structure. Please, your hands together once again for her. You see, that's why you need to come here. Now you don't hear say, he's the best you have. He's the best you have also. You know what to do. Well, that's it. But unfortunately, in this part of the world, our staple foods are carbohydrates, and carbohydrates. At the point in our homes, we eat yam in the morning, gari and soup in the afternoon, and what in the night? Rice. Wahala for people who get cancer issues. Please, hands together as we welcome to the podium again, our erudite MLS, Dennis Ekpo. Hands together as he makes his way.
Thank you very much. Good afternoon, dear colleagues. And it's a pleasure to be here among fellow professionals. Apologies for the mix-up. My presentation was sent earlier, but unfortunately the technical team did not receive it. So I'll be speaking to us this morning on accurate laboratory diagnosis, a pillar of quality health care. Accurate laboratory diagnosis, a pillar of quality health care. I'm not a scholar like Dr. Anekan, so I will try to be a bit fast. So let's go and see what this is all about. Please, next slide, please. Okay, I've attempted to define accuracy as being the degree of closeness of measurements to the analyte's true value. Next slide, please. Next slide. And then this definition of quality healthcare by the Robert Wood Johnson Foundation, which says that quality healthcare simply refers to healthcare that is effective, that is safe, that is patient-centered, timely, efficient, equitable, and delivered by professionals who are respectful, who communicate clearly, and involve their patients in decision-making. Next slide, please. Now, what is the core job of a medical laboratory service? Next slide. Simply provision of reliable and accurate results. That's how simple our job is. But the process to get this done is a bit complicated. Now, as a follow-up, please go back to that slide. We are told that medical laboratory service is essential to all aspects of healthcare. I'm sure we'll all agree with this. And that over 70% of healthcare decisions are based on laboratory outputs. Over 70%, that's very significant. Next slide, please. Now, the laboratory is a complex system that requires many people with different functions. So that makes it prone to errors. Let's move to the next slide. How do we achieve accurate laboratory diagnosis? Because it's a complex system and then we have so many people doing different things, accuracy becomes an issue. So how do we now take care of the issue of inaccuracy when it comes to laboratory investigations? ISO 15189 of 2012 specifies requirements for quality and competence in medical laboratories. It can be used by medical laboratories in developing their quality management systems and also assessing their competence. It can also be used for confirming or recognizing the competence of medical laboratories by laboratory regulating authorities and accreditation bodies. Next slide, please. Now, this is what we call the 12 disciples. Today, I'm not going to dwell on the quality management systems or the 12 quality essentials, but I'm going to be thinking more on the laboratory errors. The laboratory errors. So, if we look at this chart, we see that organization, personnel, equipment, purchasing and inventory, process control, information, documents and records, occurrence management, assessment, process improvement, customer service, and facilities and safety. Now, this more or less captures all the processes that are involved in the laboratory operation. Remember, I said it's a complex, system that involves a lot of persons. So, laboratory errors. Laboratory errors can be classified into three: pre-analytical errors, analytical errors, and the post-analytical. Next slide, please. So this is an example of few pre-analytical errors. The pre-analytical errors occur before the sample gets to the laboratory. Pre-analytical errors. And these are a few of them: improper sample collection, inappropriate request, incorrect specimen volume, illegible writing on request forms. Next slide, please. The analytical errors, these ones occur right inside the laboratory when you have received your specimens and during processing. Wrong reporting of results. Please go back. Late delivery. No. Go back to analytical. All right. Bad immersion oil, incorrect pipetting, faulty equipment, personnel incompetence, wrong methodology, and all that. So let's see the post-analytical now. These ones happen after you have finished analysis and then you have generated your result. Wrong reporting of results, late delivery of results, non-inclusion of reference ranges, making it difficult for your results to be interpreted, clerical mistakes, missing results, uncollected results, results sent to the wrong patient. Okay, let's go further. Willful compromise by laboratory personnel. This one is in a class of its own. I don't know where to put it, whether it's pre-analytical, analytical, or post-analytical. But I think we'll talk about it later, because this is the big masquerade in the room. Let's go, please. Now, this was a study done by Etam Godwin, and it attempted to apportion percentages, to the pre-analytical, analytical, and post-analytical errors, because people usually ask the question, which one is more significant, which one is more important, or which one is more dangerous to the patient. So here we see that the pre-analytical errors account for between 46 to 68% of all errors, and then the analytical accounts for about 7 to 13%, while the post-analytical accounts for 18.5 to about 47%. So you see that if you combine the pre-analytical and the post-analytical errors, they are even more than the analytical errors. That's significant. Let's go further. We'll see. Now, still attempting to explain or simplify the concept of laboratory errors, this is a half-baked analogy where I try to liken the laboratory processes to a food delivery business. Now, this business here, according to my analogy, has been broken down into three parts: getting the order, cooking the food, and delivering the food. Next slide, please. Now, assuming that these three processes are handled by three different cadres of staff. For instance, getting the food order is handled by the customer care person who receives the phone call. Cooking the food is handled by the chef, and delivering the food is handled by the delivery person. What are the possible things that could go wrong? Getting the order under the pre-analytical now, an improper order. Somebody may request for food that has plenty pepper, and then the person taking the order did not take note of it. Definitely that becomes a wrong order. You can also get the address wrongly, of whoever is ordering the food. Now, cooking the food, this one is handled by the chef, and another personnel. You see wrong ingredients, because definitely a wrong order from the customer care person would lead to the use of wrong ingredients in preparing the food. Spoiled ingredients is also possible, improper handling of food, faulty cooker, and all that. Now, while delivering the food also, the things that could go wrong, a faulty vehicle or wrong address. So let's go further. So like I asked earlier, which error affects the patient the most? What do we think is the answer here? Which error affects the patients the most? Okay, let's see what the answer is. Now, to give us a hint to what the answer is, this Venn diagram shows you that pre-analytical, analytical, and post-analytical errors, they are Siamese triplets. You cannot separate one from the other. You can't separate them. So let's go further. We'll see the answer now. All of the errors have one consequence. Next slide. Next slide, please. Poor patient care. They all lead to poor patient care, whether it's pre-analytical, whether it's analytical, or it's post-analytical. The consequence is the same. Poor patient care. And that's a list of all the things that can happen. Just a few of them, not all. A few of the things that can happen which qualify poor patient care. Okay. Remember that the goal is quality health care. And we had defined what that means at the beginning. Okay, let's go. What happened? Okay. This is a popular statement. To err is human. Now, this statement is used to justify some of the mistakes that we make, while working in the laboratory. Oh boy, I know be computer, I know be machine. Person know they make mistake. We are going to see to err is human. Let's go further, please. I brought out some real life consequences of laboratory errors just to show us that to err is human when used in the laboratory has actually caused families some real anguish and trauma. So let us see. I brought some cases. This one made the news in the year 2005 for those of us who were already in the profession then. Baby Eniola in Luth, who tested HIV positive after being transfused with HIV positive blood. Now imagine the trauma meted out to the parents of this baby, and even the innocent baby who has now become HIV positive because of an error committed by one of us. A baby who came to the hospital to be healed, to access quality health care. So somebody did not do what he was supposed to, or he or she was supposed to do, and then resulted in this incident. Of course, people were punished, people were sacked and all that, but it didn't change the fact that that baby remains HIV positive. Yes, let's see the second case. This one is common, is everywhere. A young couple took premarital genotype tests. The results showed the man was AA while the woman was AS. They got married and gave birth to a baby who was always in and out of the hospital. Investigations on the baby revealed that the baby's genotype was SS, thereby casting doubt on the paternity. A repeat genotype testing of both parents showed that the father's genotype was actually AS and not AA as was issued during the premarital tests. Because somebody did not do what he was supposed to do properly. Because somebody did not do what he was supposed to do properly. People who were not supposed to get married in the first place got married and then gave birth to an offspring who has come into the world to suffer the consequences of sickle cell anemia. Because somebody made a mistake. A young man in his late 30s was diagnosed of diabetes mellitus. His health continued to deteriorate despite the fact that he was being managed for DM. It was later discovered that he actually had hepatitis B infection, and he eventually died from complications of hepatitis. Now, if you look at this case, the problem may have been ordering the wrong test. ordering the wrong investigation. Remember, we mentioned it as part of pre-analytical error. Yes, so this is what happened now. Somebody died because the wrong test was ordered, and then the doctors were chasing the wrong disease rather than what was actually the case. So this is case 4. A young couple was proud parents of a baby girl until routine tests cast doubt on the father's paternity. The couple split up over this issue but reunited some years later and had another child. Knowing the first child wasn't his, he insisted on a paternity test. They subsequently learned the first child was his and that the original test had been compromised. Imagine how many years and the back and forth simply because somebody made a mistake. Somebody did not do his job well. Case 5, please. Over 100 patients tested positive for prostate cancer from a prominent institution. Some patients underwent treatment for non-existent tumors. The problem was later determined to be due to errors by equipment, personnel, and procedures. Is that an excuse? In a prostate screening program. So this one is also very pathetic. A young lady had her right breast removed surgically after an incorrect laboratory result showed she had breast cancer. They had taken off the breast and then sent the breast tissue back for analysis, and they didn't find any cancer cell. So who did the initial diagnosis on the biopsy? A mastectomy. The damage had been done already. This one is the big masquerade. Willful compromise by laboratory personnel. Can anybody attempt to tell me what this one means? And possible example. Willful compromise by laboratory personnel. I think we should be used to this one. Okay, please.
Okay, willful or compromise. Sometimes we carry out a test or analysis, and then the analysis does not match, the result does not match with the complaint of the patient, and then you have to give out a result that matches with the complaint of the patient. So at that point, you have compromised what you're doing. Sometimes someone will present with symptoms of malaria and typhoid. At the end of your analysis, no typhoid, no malaria, and you're like, what am I going to give to this patient? You just like, let me just report 1+ for the patient and let the patient go and take anti-malaria.
That's a great attempt, but I don't think you've gotten it completely. Let's hear from another person.
Okay. Good afternoon, all. I believe that, okay, like someone coming to your lab, this happens to me actually during the COVID era, because I happen to be the focal person for COVID diagnosis in my laboratory. A woman, a nurse, approaches me and asks that there are some people who are to travel. I think about that time we can still give out results from your facility. Just give out the number, the unique identifier, and once they get to the airport, they punch it in, and once they see the result, they allow them to travel. So she said she had about 9 people. 4 of them are in Ogbomoso, 4 of them are in Lagos, and 1 of them is in Ibadan. I happen to stay in Ibadan, but I work in Oyo town. So I asked, she now said, can you help us write out the results? You know, they want to travel. I think they were going to Europe. I said, where are the patients? I mean, the clients. She said, there is no need. I mean, no, they are all healthy. They are fine. I said, you said they are fine. I don't know whether they are fine. Those that are in Ibadan, the person in Ibadan can wait in Ibadan. Those that are in Lagos can actually, you know, the lockdown has been eased, can actually take the train, meet me in Ibadan. Those that are in Ogbomoso can just take like 300 naira transport and meet me in Oyo. I will diagnose all of them. I will go with the kit down to Ibadan and diagnose those in Ibadan, and I will give you your result. Peradventure, because of the financial gains she's offering, I decide to look the other way and then give out the results. That is a willful compromise, because I intentionally allow her to nudge me to to compromising.
Thank you very much. Brian, is it the same thing? It's close.
The willful compromise by laboratory personnel too has a lot to do with us as scientists on the bench. Nonchalance. Okay, this is a angle I'm looking at it from. Nonchalance, lackadaisy attitude towards our work. Okay, postponing work is not my work. Another person will come and do. A lot of this can compromise the standard of our work. Thank you.
All right, thank you very much for all your contributions. Willful compromise is when you accept monetary inducements and issue a laboratory result that is demanded from you by a patient. For instance, somebody walks to the lab and says, I'm getting married to this babe. I need you to give me a genotype result that is AA, AS, or AAAA. Please, we have gone far. We cannot take the risk of going to start afresh now. Again, I will pay you this, this, and that. And then you have mercy on him and pick up your laboratory form, write a result, and give that to him. Another one, this one happened to me. A lady walked up to me one day and said she wants a positive pregnancy test result. And I said, okay, that's not a problem, but I will need to take your sample. And she said, no, you don't understand, sir. I mean, just give me a positive test result. I said, what do you want to use it for? There's this man she is dating that she doesn't want to lose. So she needs that positive test result to maybe secure the relationship or whatever. But I politely told her that, sorry, I don't give out results when I don't see sample. I don't just write result. So whether you want positive test result, give me sample. And I'm going to run it. Whatever the sample tells me is what I will report for you. Sorry. So she had to go somewhere else. She didn't come back to me again. You see, but there are persons, there are colleagues who will receive whatever it is she was offering and issue that result, thereby compromising, you know, the standard or whatever it is, or the ethics of this profession, the oath we took as medical laboratory professionals on the day we were inducted. So I said this is the big masquerade, that willful compromise. Now, willful compromise, we know that it comes under misconduct or unethical conduct. But when it comes to laboratory errors, is there any way we can squeeze it in there? Analytical, pre-analytical, or it stands on its own? It stands on its own. And it is, of course, a very significant danger. So while I round up, I wish to recommend that laboratory management at all levels should ensure the implementation, operationalization, and strict compliance to a laboratory quality management system, because by so doing, we would have eliminated or reduced laboratory errors as much as possible. So the MLSCN, as part of its core mandate, is required to ensure ethical conduct by all medical laboratories operating within its sphere of regulation. So in conclusion, accurate medical laboratory diagnosis is critical to achieving quality health care. Functional quality management systems in our laboratories will ensure that laboratory errors are reduced to the barest minimum, just like I said before. And as medical laboratory scientists, we have a moral burden to serve and protect our patients. And finally, handle every sample as you would your relatives. Thank you very much for your time.
Please your hands together again for MLS Dennis Eko. Powerful, powerful, powerful. I think we should really dwell here because this is who we are. This is our house. So we are trying to tidy up the here and there. Willful compromise, hustle. Oh boy. Hustle. No, don't be pay. Pay. Please. It's not ethical. Do the right thing, right? And the people that want to jackpot, that's the bad thing. You can't go with this mentality. Willful compromise. Won't go do anyhow there. Go enter jail straight up. Please. That's why we're here. Once again, let's celebrate the leadership of this forum. Please your hands together for our president. He's doing well. Of course, this is not easy. Look at the knowledge we're expending and dashing people. Thank you very much. All right. Thank you very much, sir. God bless you. You did very well to that. Please, the materials will be sent across to us. We need to have this. Take it to your facilities and also educate and enlighten others, especially our interns. Especially our interns, because you're like the future. That oath you swore. That oath you swore was to make sure that you save lives. That is the most important thing, and not any other thing. I see my brother, my friend, and my Ogatu. Please, let's celebrate MLS. Andy Ewa is in the building. Your hands together for him. I celebrate you, sir. Yes, we have done great things together, sir. I greet you. You're a good man. A very good man. He's a good man. All right. Please, at this juncture, we would like to celebrate grace and give honor to whom honor is due. Before our third lecture from my own father, someone I respect a lot, is, fatherhood nowadays, not by age, capacity. Please, let's celebrate and honor this wonderful lady that was our first speaker. There will be an award to appreciate her. Please, let's celebrate as she makes her way, Dr. Anyekan Augusta Ayo, for her award. And to present this award, I want no other but the secretary. Capacity Chege is a good man. Please, let's celebrate MLS Jegede as he presents this award of appreciation to Madam that has done well for us as a resource person. Please, your hands together as he makes his way.
Thank you very much, my able MC and my leader. Yes, I am the secretary. I would like to breach protocol a little bit. I think I have someone I will have also called to join me in presenting this to our doctor, our presenter today. Please permit me to call on my leader, scientist Ewasin. Please come and join me, sir, to present this award. Please, let's celebrate him. He's a senior man. He's one of the men that has done great things, just like you have said. Details later. My leader, please, help us do this.
Thank you very much. An award of appreciation presented to Dr. Anyekan Augusta Ayo, our guest speaker. This award is presented for your excellent presentation, impartation, and significant contributions in increasing the knowledge base of our members in the 4th Annual Public Health Lecture in Uyo, here in Akwa Ibom State, and the YMLS across Nigeria jointly says thank you today, the November 11th, right? 2022. Congratulations, man.
Leave it to me.
Thank you very much. Let's celebrate them. Let's celebrate them. Yes, it's not easy to show capacity and show leadership. And I also learned that mentorship is key. We should learn. We should learn. It's very important. All right. At this point, we'll be having our third lectures. And of course, I said he is someone I respect a whole lot. I've learned a lot from him, and I'm very proud to say so. He's a good man. When you see good men, celebrate them. He is a lecturer. He's senior lecturer self for that, man. Please, let's welcome no other but a man I respect a lot, and I know he will be doing justice to this topic. Conducting a quality biomedical research in an habit economy environment or economic environment. Please, if your hands are just with you and they are alive, please your hands together to welcome Dr. Kemsi Elechi Amadi. Your hands together. He's a proud Rivers man like me. We are proud people. I greet you specially.
Thank you. Good afternoon. Permit me to stand on the already established protocol. Next slide, please. For this brief talk, we'll follow this outline. Next, please. Conducting a biomedical research. Let me start from saying one or two about that word biomedical. In the general sense, it encompasses us and our brothers in basic medical sciences. So in the medical world, generally, we have biomedical staff or researchers and clinical researchers. We are somehow in between, but we are more of biomedical. Then, if you go to UK, since it is a protected title in UK, if you use this term biomedical, they'll be looking at our colleagues over there. But for the purpose of this class or this lecture, we'll limit it to what research is all about. So biomedical research is a broad area that essentially deals with finding out what is, substantiating what has been theorized, developing new therapies or disease management protocols. For those who want to find out the foundation of what is, our brothers in basic medical sciences, and for those of us who want to substantiate treatment modalities or even develop new diagnostic or management procedures, we are there. So it can further be classified into two, like I said before, basic and applied. Those in basic will do their basic. Those in applied will do the application. Of course, we all passed through anatomy, physiology, biochemistry, pharmacology before we came here today. And that is what is this lecture. But next slide, please. Like I noted earlier, in applied, we do all that we have to do with this. Having acquired the knowledge from basic sciences or basic medical sciences, and you do apply them in doing what you do, whether it is developing new diagnostic procedure or even treatment regimen. When we talk like this, we as an only pharmacist there. If you have ever done sensitivity tests, you have done something close to applied biomedical research. Because what you are essentially trying to do is which of these drugs can be used to manage the infection. If you have ever looked at even herbal substances and looking at their medicinal value, then you have done something in applied medical research. All right, next one. We are going to be fast with this. Next slide, please. So essentially, biomedical research comprises what we have there, the study of specific disease and condition, whether mental, physical, whatever, including their detection, cause, prophylaxis, treatment, and rehabilitation. It also encompasses the design of methods, drugs, and devices used for that purpose. The scientific investigation required to understand the underlying life processes which affect disease and human well-being, including all that are part of the biomedical research. So if you understand this now, we know that the MLS is at the center of those that should provide solution when it comes to biomedical research. When we understand where we are, and we then ask ourselves how far we have gone in carrying out this search for solutions. Next slide, please. Now, a close examination of the key concepts of biomedical research indicates that we are at the center of it. Whether you did physics, chemistry, biology on your way, along the line you did anatomy, physiology, biochemistry, pharmacology, microbiology, basic. And somehow you came into the clinical areas and you started doing pathology and all that. You have moved through. So if there's any group at all that is a blend of basic sciences and medical sciences, it is who? Lab scientists. There's no way they will talk of this chemical can do this, that you won't know what it is. And there's no way they are talking of reagent preparation that you won't know what they are talking about. At the same time, there's no way they are talking about pathological basis of diseases that you don't know. What I want to point out here today is not just talking about this, but how not well we have played our role in that regard. Next, please. So what is quality biomedical research? When we're talking of quality research, research has procedures. From ideation, somebody talked of that word here today, ideation, initiation of the idea, to asking the questions, working hypothesis, methodology, analytical tools, and then the results. If that is the case, we shouldn't be lacking. Is anybody here without a BMLS at least? All of us have BMLS. Cast your mind back to your research, what you do in your project, BMLS project. Can you be proud of what you did? Truth is that some of us dabble our way through. So much, and some give our work to be written by others. So much so that when you even come to your supervisor and they ask, this is my own experience. Somebody brought the work and used some acronyms. So, boy, what does this mean? He that brought it did not know the meaning of what he brought to me. Did we pass through that same process? Now, if you don't know what it takes, you need to think of something. When Dr. Nyekan was presenting, I was just asking myself, how did somebody conceive the idea? Okay. How did somebody conceive the idea to look at stool as a way of diagnosing TB? Somebody thought about it. That is the ideation, the idea. Oh, children can cough and swallow, so we can't get sputum from them. And the molecular diagnostics procedure is expensive. Government don't want to invest. So what do we do to help our people? Somebody conceived that idea. That is the basis of our training, actually. Ask questions and be able to answer the questions using appropriate protocol. That is the whole essence of biomedical research. And when the MLS, the oracle, has refused to speak, there's nothing any other person can do. All right, so quality research most commonly refers to the scientific process encompassing all aspects. Essentially, we are talking about the judgment regarding the match between the methods and questions. What are the questions? Research questions. Your research must provide answers to some questions. Are you using the appropriate methods? Selection of subjects. You cannot be looking for TB in somebody who has diabetes and without the TB. Will you get the answer? No. Measurement of outcomes and protection against systematic bias, non-systematic. There's always a bias. If we are not careful, we want the results to go this way. But what we are seeing does not agree with what we have in mind, or you're already biased. You're trying to gather everything to suit what we have in mind. As a researcher, you should be able to remove. Of course, that leads to willful compromise. Once you have that idea that you must be biased in your approach, then willful compromise will be very easy for you to do. Okay, so in other words, quality biomedical research refers to compliance with required standards and protocols in order to ensure credibility and reliability of the data obtained. All right? Okay, features of a quality research. It must be relevant. Your research must be relevant. You know, if you're in academics, they begin to tell you statements of the problem and justification of the study. At the end of the day, before you begin to talk of objective and hypothesis, at the end of the day, what have you been able to do? You can't just go and do anything and come out. You think you have done. Your research must be relevant. It must be reproducible. By the time you have published your work, somebody can pick up what you have done. Maybe you published it here in Akwa Ibom. I can go to Lagos. Oh, Christopher did this work in Akwa Ibom. Let me do a similar thing in Lagos, can I get the same or similar result as you have obtained earlier? If not, then it's a problem. A very good example is when we want to do experimental research. You know, research is broadly classified into two, observational study and experimental study. In observational study, you just collect sample from patients that have the disease. For example, you're looking at the TB we did earlier, you want to collect their sample and run and see what is happening to them. You did not give them the disease. They already have it, so you're observing what happens. In experimental study, you cause the condition, and that's why most times you use rats. You don't go call me and say, "Want give me TB, then study me." No, now, or HIV. So we get rats, induce the disease condition in the rats, and then monitor the protocol, harvest the organs or tissues we want, and do what we want to do. So when that happens, you find out sometimes the chemical you want to use, you can't begin to go all about establishing the LD50. So, oh, Elechi has done this work 3 years ago. Let me use his LD50 to do the work. Sometimes we find out that by the time you induce the rats with what I called my LD50, they are all gone. They die. What does that tell you? Adabo they work. Right? Are we with me? Please, so if I'm deviating, just call me back. Let's interact more. All right. Your design should also be such that we yield the results expected of that study. Next slide. It should be ethical. There are standards you have to keep to. So ethical approval must be sought in what you're doing. Even in rats, you know, we don't have animal rights here in Nigeria. But sometimes you publish your works and they'll tell you, why are you using 20 rats in a study you can use 7 rats for? And we're going to look at you. Sometimes they reject your publication. So we have to conduct our research according to ethical standards. Your research must be reliable. Report what you have seen. Don't go manipulating. You know, it must be auditable. By the time they look at your data will such that reflects something that, you know, when people that have experience read your work, they begin to, you have idea if what you have done is in order or not. And then the most important part, your research must be in the public domain. After doing your research, you don't publish your work. How would people know? How will people know you have done something? And this is where, again, MLS is far behind, especially those of us on the bench. On a daily basis, you generate data, whether in the public labs or private labs. If I want to do a retrospective study of diabetes in Akwa Ibom, can I go to the teaching hospital and the general hospitals and get data from 2010 till now of how many people were diagnosed of diabetes in the States? I don't think we have that. But we have scientists who are generating the data. That is why pathologists will come. No worry, just give me your result booklet. Yeah, copy. Where are your result? Your result for today, the copy. How far now, how you doing? Okay, we'll see tomorrow now. High five, they go. Tomorrow, that small boy becomes a consultant pathologist and becomes a professor, your HOD. I like, look at you. You that I trained here, I was here when you came. He used what he could not use to achieve his aim. Do you blame him? The moment you begin to publish your findings, they cannot copy you. If they copy you, it's plagiarism. You can sue them. But if your journal, where you want to publish, finds out that what they are bringing is what you have done already, they can take care of them from there. So you will always find them, if you do that, coming to you. Okay, let's collaborate now. But the majority of us, MP, positive, the year ends, nothing. You come and collect and publish and tell you prevalence of malaria in Igor. How did they get it? Did they go to the lab? Who generated the data? But our works are not published, so we have a problem there. The conclusions you will get from your research should be justified by the data you have. How do I explain this? At the end of your research, you will conclude this is what you have found out. But you find out that some of us just put anything there just so that we have done something. Your data will not agree with what you're saying. And the question is how? Okay, you did hematological changes in pregnant women. At the end of the day, you're not telling us that pregnant women with diabetes should. Meanwhile, you didn't do pregnant women with gestational diabetes in your work. How did it take enter the work there now? Are you following? So your conclusion from your study should be justified by the data you have from that study. Now, the greater confidence in research is achieved if the researcher is experienced. You cannot do without experience, and you cannot just jump into research. So the experience is important, and you don't acquire experience by staying away. You acquire experience. Iron, they say, sharpened iron. You align with colleagues, you talk, you exchange ideas. The most important aspect that defines quality of research is what? Is what? Methodology. For those of us who are coming to do postgraduate study, where we wait for you is in your methodology. The introduction, speak all your grammar, no problem. You want to look at hematological changes in people that fly a aeroplane, no problem. When you are done, we now go to your methods. How did you do this work? From subject selection, how did you select the pilots? What informed your choice of that, those people? How did you select your control subjects? Are you together? How did you collect their sample? These are all methodologies. How did you preserve the samples from airport to the lab? Did you analyze samples that day? Did you preserve till the next day? How? Which method did you use for WBC and all that? By the time you finish and you have done quality work, naturally, the output will also be quality output. But once there is a comma somewhere, and once your methodology is wrong, that means your results are wrong. You are going back to the field. All right, next slide. So preparing for research. How do we prepare? Let me state here that I see every MLS, every male lab scientist, as a born researcher. If you have passed through the training, appropriate training, you are a researcher already. And how does that come? If you have ever generated data in your lab, then you have done research. Why? You must have followed SOP in generating the data, right? Okay. Now, one, acquire the necessary skills and experience. Like I said before, greater confidence in research based on what? Of the researcher. You cannot do this. It's not enough to have passed through BMLS training. What have you been up to after that? You and I know that that is not enough to give you all the knowledge and skill you need. Like this, my sister here, if she handle, and Dr. Julie, if they go to molecular research, me, I will be their student in that area. Are you getting it? And now I want to go and do a research that has molecular components, and I don't want to acquire the basic knowledge of that. I can't even explain my results. That is stupidity. No? All right, so acquire the necessary skills and experience. You cannot do without that. Identify research gaps in your area of research. Now, there's nothing new under the sun. But we are all humans. We have limits to what we can attend to at every point in time. So, read up literature in the area of research you want to do. And then when we say gaps, that is, gaps are the answers in those areas that have not been provided. Somebody did this, okay, this is a method he used. Can I use this method? Somebody publishes one. I'm going back to TB because we just did the lecture. Somebody has used Gene Expert to do TB. Okay, can I use, like she said, take a stool, sit in 2 minutes, what did she call it, and then do the same aspirate using the machine, but the thing is smelling. Okay, Can I do the same thing and arrive at the same result? You have used a different method. That was a gap that the person did not do. So look for what the person in that area of research, that's what we mean by gap, and pursue it. Identify the resources you need, whether finance, facilities, and all that. Nigeria is very poor in terms of research facilities. Let's be frank about that. Our teaching hospitals are a bunch of disappointments. I was at UUTH last night. Even electricity was not there. And I said, well, it's not different from my own teaching hospital where I'm coming from. So it's a problem we have all around. So before you go on to do a particular research, identify the resources you need for that research, and then tell yourself how you want to go about overcoming the challenges. We'll get there. Seek collaboration, partnerships where necessary. Now, a tree cannot make a forest. In research, even advanced countries encourage collaboration. At the moment, I'm supervising a student, MSc student, who is working on radon gas. I'm a co-supervisor. But for us to get that work done, we needed to go to physics department to borrow their equipment to measure radon gas. Is the gas that comes out of cracked walls. So as this building is, if you notice cracks anywhere on the floor or the walls, you know that the materials used when they were building the house, there were trapped gases. And then the materials used in building the house also are elements. When they age, they emit gases. Those gases are known as radon gases. We now want to look at the health implication of that. Now, we had to go to physics department to seek somebody's assistance there. That is collaboration. Because we know that in MLS department alone, we can't achieve what we want. So we must seek collaboration. Another area is when we come to like grants. If I am in an institution and I have access to research grants, you are not in any institution, you don't have access to research grants, but you have the idea, you will need to come. We discuss how we are going to do it, reach an agreement, then apply to a grant agency to give us money for that research. If you stay on your own, they will not give you because you are not a staff of that research institution. If I stay on my own, I will not do it because I don't even have the idea you have in your head. So what do? What did the band say? Oh yeah, make we collab, right? Okay. Proceed with your study, having sorted out what you need. At least on a preliminary stage, you start. And as you start, anticipate challenges. Right now, we want to do a research on febrile seizures. We want to induce convulsion in rats and see how we can use palm kernel, oil, and other herbs to treat febrile seizures and justify what some people do. To get on paper, it was okay. Everything went fine. We did the proposal fine. Now, getting the reagents, it's costing almost 700,000 to get the reagents we need. And you know now, how much a lecturer salary be? We have to start saving the money. So anticipate challenges and failures. Like I said before, you can borrow, you want to do a toxicity study. You inject something in the rats, and they all die. You recruit people for your study. Along the way, they say, want to use my blood for ritual, and then they do it again. They decline. You cannot force them. These are challenges you must anticipate in your study. Okay, that leads us to these challenges. Number one, of course, is finance. Yes, in Nigeria, TED Fund gives research grants. I think 1.5 million or so. So you need to design work that will not cost more than that amount if you are doing a research. And again, it is purely for university staff or polytechnic staff. I think to some extent, colleges of education. So if you're not a staff of higher institution, TED Fund will not answer you. That's one challenge. The government is not willing to bring out the money they will loot to give you to do research. They won't do it. They rather spend that money on political campaigns and all that. So One of the challenges, in fact, the major challenge of biomedical research is what? Lack of finance. Then, inadequate research facilities. As we said before, we don't have enough facilities. There are many things many of us would have done, but we don't have the research for that. Tissue culture. I don't think we do tissue culture in this part of, I think the place ahead of it is in Ibadan also, or Lagos. In this part of the country, we don't do tissue culture. And that is one of the good methodologies you must use in research, yet we don't have it. Unfavorable disposition of government towards education and research. All of us know what the federal government has done with ASU. But they forget that no country can ever grow beyond the capacity of an intellectual class. See, like I told somebody before, Russia went to Ukraine, Ukraine went to Russia. They are almost at par. Why? They invest in research. You cannot throw bomb missile in Israel today and it works. Why? They did research to find a shield, and that shield is in the air. As your missile is coming, it is neutralized up there. The people are free. Why can't we invest in research in Nigeria? So that is one of the challenges you may have as your for your research. Power supply. If you were here earlier today, but, the light was down, and if in your house you spend more on generator than the public, so that is a problem too. There are equipment that requires public power supply, which the generator may not do. With the high cost of importation of reagents, we don't produce anything here. That our senior brother, a senior colleague is selling some things there. Look at all of them. None is manufactured in Nigeria. They were all imported. Ask him how much he used to import them for sales. And now you're going to buy to do your research. Tell yourself how much you're going to spend. So it's a very big problem. But in problems, full of technological advancement, of course we are nowhere technologically. Even areas we have to do knowledge transfer, technology transfer, we don't as a country. If not, we would have advanced beyond where we are now. And since the technology is not there, the technical know-how we who are going to do research is also limited. Inadequate mentorship, supervision, and poor mentee attitude. If you have passed through, all of us have passed through. Some of us, you begin to narrate your experience with your supervisors. Some of you say, God punish him. Right? Hello? Are they lie? A few of you will say, God bless that man or God bless that woman. If not for he or him, I wouldn't have graduated. Others will say, now they work for the daughter. If the daughter come this, if I see them, what thing I go do them, it's a problem. We see supervision as a way of stressing people, milking them. Others will make sure that you bring your whole salary to give to them before they look at it, even read your work, before they collect it from you. But on the other hand, too, you, the mentee, you are not willing to learn. So even when you find somebody who is wholeheartedly interested in mentoring you and teaching you, your attitude encourages the person. I think we need to work on ourselves in that area. Poor volunteering attitude by research subjects. There are areas of research need people to volunteer. If you bring questionnaire here now for us to even fill, I beg, what you go give me? I know the feel, give. That's a questionnaire. Then imagine people you want to collect urine or blood for. You want to use it to do ritual. Where is he from? They say from Ekora Banabia. We talk them. They are village people. Every family has native doctor. I don't want to give my sample. So such poor attitudes also affect our research. Some intending researchers not having adequate knowledge and understanding of the area they want to research into. This is a problem. Like we noted earlier, you must know the knowledge gap in the area you want to research into. So when you now come here, it won't be a problem for you. Next slide, sir. Now, since finance is a major problem, if you have money, you can solve the other problems of research to a large extent. You can buy a generator, a big gen like we have here, to power your lab. You can order for reagents and all that. when I was doing my PhD work, I worked on arthritis. My professor said, why not do this work in triplicate? I said, Prof, I don't have that kind of money. He said, university gives grant. I have forgotten that this is not UK, this is Nigeria. I said, yeah, thank you, sir. So do it in duplicate. And only God knows how to survive that time. Because it costs much to import these reagents, and you have to repeat that the whole procedure. Just reliable data. It's not funny. So funding and grant agencies, some exist. I hear CBN also does something like that, especially for research into COVID-19 and other diseases. So if we can identify these funding agencies, read their requirements. Every funding agency has her requirements. What they want you to do, how they want you to do it, and the protocol they want you to follow. When you get to anyone, understand their requirements, arrange your proposal, and forward to them. Once approved, guy, you make it from there. Okay, these are the people I referenced while preparing this work. Thank you very much.
So it will interest you to know that he's not just telling you what he doesn't practice. My first research work for my life, I didn't know jack. If not for this man, please celebrate him again. You guess why? I celebrate you greatly, sir. Mentorship is key. Mentorship is key. You keep learning. Follow who know road. You get why. All right. So just take 2 questions. And of course, after those 2 questions, we'll be presenting an award. And we'll go to our other classes. And after that, prepare your beach cloth. My friend Kema, I love you, my brother. Prepare your beach cloth, because we are going there after here. The president just told me that it is happening. So when I get ready. All right, just 2 questions. 2 questions, please. Research in an abate economic country. Wahala. No question? It is of no doubt, I know he's a very, very good man with the oratory of a god. And in that note, let's celebrate him once again. Your hands together for Dr. Kemsi Elechi Amadi. You're a good man. God bless you. All right, we'll be presenting an award. Sec. You know, we celebrate greatness here as YMLSF. Make sure we celebrate greatness. So visibility is key. If you like to receive award, be visible in everything you do. All right, we'll be honoring somebody, but to present that award, I want my brother, my friend, Precious Kiekili. Please, your hands together for him. He is the Vice President of YMLSF River State. Keep clapping, it's coming. And also, information is also the NOC Secretary. I celebrate you. All right, to present this award is standing here, and the awardee, please let's celebrate MLS Dennis Ekpo for his award. Your hands together as MLS Dennis Ekpo makes his way. Your hands together. Capacity everywhere. Wahalo.
Okay. An award of appreciation presented to MLS Dennis Ekpo as guest speaker for your excellent presentation, impartation, and significant contribution in increasing the knowledge base of our members in the 4th annual public health lecture in Uyo, Akwa Ibom State. Thank you, sir.
Thank you very much. And also in the same vein, we'll be honoring another person. And of course, to present the award, please, your hands together for the Vice President and the NOC Chairman, MLS Patrick. Your hands together as he makes his way. Your hands together as he makes his way. And to receive this award, please, let's welcome my father. Please, your hands together as we welcome Dr. Elechi Amadi. Your hands together as he makes his way. A good man indeed. Correct. A biggie man. I don't know that song. You see, I need to learn before I come over here.
Thank you very much. Award of appreciation presented to Dr. Kemzi Elechi Amadi as guest speaker for your excellent presentation, impartation, and significant contributions in increasing the knowledge base of our members in the 4th Annual Public Health Lectures at Uyo, Akwa Ibom State. Thank you, sir.
Thank you very much. Yesterday I mentioned that we should try as much as possible to network. It's very important you do so. In as much, are you doing that? You are doing well. You are doing well. And my brother also mentioned that we should know our boundaries. If you are married, do hand like this. Hello, can I? You get why. You get why. All right. We'll also be presenting an award to a strong capacity mentor, father, and founders of the matter. Please, to receive an award. To receive an award today. And on behalf of the awardee, we'll be having the immediate past president of this wonderful forum. Please, let's welcome MLS Jeff Isioma Chilodi. Your hands together as he makes his way. Our capacity immediate past president. Another man I respect a lot. Follow no road. He gets why. He'll be receiving this award on behalf of Dr. Chris Mbata. Your hands together for Dr. Chris Mbata. And to present this award, our national welfare in our capacity will be doing that. Your hands together as she comes. Welcome our national welfare capacity everywhere. Wahalo for person who don't know road.
An outstanding award, outstanding leadership award, presented to Dr. Chris Mbata JP for your outstanding leadership, significant contributions, and support towards the growth of the Young Medical Laboratory Scientists Forum of MLS profession at large. Congratulations, sir.
Before people leave here, I'll teach you a song so that you take it to your... You know we are a national body. And we need to do national things. And I'm a Rivers man. My name is Aaron Spiff. You know, it's in Rivers, Wansa, Spiff, Bombs, all those kind of names. So I'll teach you a song. Now, the song goes this way. So you are taking this song home. Kekile, come. Come and answer and I'll sing your answer. Come fast, we don't have time. So that they will join us. You can't come to conference like this and you don't learn one thing, at least one for the streets. One for the streets. Fast. So, the song goes like this. If you say capacity person, we get levels. We don't show capacity for the matter. and you want to celebrate him as young people, I will be the singer, you will be the responder. I will say, it's either a big man or a good man. So let's start with what? A good man. I will say, a good man, a good man. He will reply,
A good man, a good man.
I'll sing again, a good man, a good man. He will reply,
A good man, a good man.
I go say, he no dey for size oh.
A good man, a good man.
Say, a good man, a good man. I believe we are intelligent people. Two, go. A biggie man, a biggie man. A biggie man, a biggie man. Say, he no dey for size oh. A biggie man, a biggie man. Oh, your hands together for yourselves. You take that one home. All right, quickly, we'll be having our next speaker. And of course, he will be finishing work. Then, of course, they've been signaling me that the beach is ready. Please, let's welcome for his own lecture on preparedness and response to outbreaks through the resilient laboratory system, the COVID experience. To do justice to this, please let's welcome Dr. Julie Johnson. Your hands together, she makes her way. Your hands together. For not do too much now, give her a song to sing. Your hands together.
Thank you. Good afternoon, all. Please permit me to stand on the already established protocol as I make my presentation. But first of all, I want to say a very big thank you to the YMLS National for giving me this opportunity to share in this wealth of knowledge. I look forward to where you enjoy the presentations and then be motivated to look at molecular as the way forward. Thank you. I'll be looking at the topic, preparedness and response to outbreak through the resilient laboratory system, the COVID-19 experience. Next slide, please. Now, I have an outline that will look at the introductory aspects and also what the public health laboratory system as with regards to the COVID-19 pandemic. Then what was the rules of the public health laboratory in disease outbreak? We'll also look at factors that affected the public health laboratory system. And we'll look at the conclusions and finally make recommendations. All this will be in perspective to COVID-19 experience. Introduction. Disease outbreak continue to be a significant risk to public health. Sorry. I'm not seeing. Sorry, let's make some little adjustment. Say it again. Okay, bring it up again. Okay. So the first slide actually looked at the risks we face with outbreaks. Outbreak has always been a major risk to healthcare system. Now, when we look at the historical perspective, we realize that there have been some records. One of the historical perspective was the 1918 Spanish flu, which was caused by influenza A virus. We also have outbreaks that were documented in 1957 and 1968. They were all caused by different variants of the influenza A virus. We had the 2002 severe acute respiratory syndrome, which was caused by a coronavirus. Next slide, please. Then the Ebola hemorrhagic virus fever, which was also known as the West African Ebola outbreak. This occurred between the span of 2013 and 2016. This was a fatal outbreak too. Then here comes the COVID-19 experience, which all of us witnessed this. In perspective, at least all of us here should have been in practice at when we had this outbreak. Now, historically, it was documented that the outbreak actually took place at Woodham in December Now, that documentation, Africa experienced its first documentation of that outbreak on the 14th of February 2020, and Egypt was the first country that actually recorded that. Barely 14 days after that, Nigeria recorded its first index case, and that was in 27th of February 2020. Now, my beloved state, Akwa Ibom State, had its first index case on the 1st of April 2020. At first, we thought it was an April Fool, but we had to face reality. What we taught in school now was something that we had to put in practice. And, of course, there were so many short outbreaks. Now, the healthcare system across the globe, because of this COVID-19 pandemic, has struggled to contain the unprecedented shock arising from this novel virus. Now, why was it so? It was novel. Since it was a novel virus, little was known about it. Unlike other viruses that already you have established protocols, you must have kept things aside, you know how to handle it. So since it was a novel virus, it posed a challenge of, first of all, trying to understand the virus before you now even know what response to even mount on the virus. So this was one of the major challenges. Next slide, please. Now in Africa, already we all know that our healthcare system is nothing to write home about. Before it came to Africa, we had evidence of what was happening around the globe of the sites that we know had a very good healthcare system. So naturally, it was something of concern. If sites that have a good healthcare delivery system were overwhelmed by this pandemic, what could become of Africa? So Africa was a thing of concern during the pandemic. So response to disease outbreak actually requires a very vigorous public health approach. Now, unlike your clinical laboratories, the clinical laboratories are laboratories that can actually stand on its own and then provide service delivery. But the public health laboratory cannot stand on its own. It has to depend on the healthcare delivery system. Same thing with the public healthcare system in general now. The healthcare delivery system can stand without the public health delivery system. What am I trying to say? The public healthcare delivery system must always work in conjunction to the existing healthcare delivery system if we want efficiency. At this point, since we already have a very weak healthcare delivery system, government was actually encouraged by WHO to improve their healthcare delivery system. Then this encouragement was led by advocacy to clearly define what we call resilience against what was the fragility of our own systems. Next slide. So based on this, fragility was defined as the insufficient capacity of states, systems, or communities to manage, absorb, or mitigate disease outcome. Whereas the healthcare system resilience was now defined as the ability of the healthcare or institute and population to demonstrate absorptive, to adaptive, accessibility, and transformative capacity to prepare effectively to respond to healthcare shocks. Now, these healthcare shocks here, we are looking at specifics to the outbreak. In other words, what this is telling us is that ability of the healthcare system to protect life. And in the definition, it says all life. So in other words, for you to achieve resilience in healthcare delivery, your response system should be in such a way that whenever there is an outbreak, you are able to respond to it without a loss of life. It's only when you achieve that you say your healthcare system was resilient. Next slide, please. I have said that. And if you're looking at healthcare resilience, it entails a lot. Healthcare resilience is not something you just wake up and you achieve it. Now, why am I looking at healthcare system? Now, it's only in accessibility of healthcare system that we can now look at the laboratory resilience. Now, for you to achieve resilience, there are certain factors you have to look at. It's not something, like I said, it's not something you achieve overnight. It's something that you have to look at your capacity and other factors. So what are these factors in order for us to achieve resilience? We have to be able to assess, have an advanced assessment of our system capacity. Now, every healthcare system, whether weak, fragile, or resilient, has its own capacity. And the ability to assess that capacity and then look at what are your weaknesses. Now, your weakness can be looked at from perspective of your last response. From there, you're able to know that, okay, from the previous response, this was our weakness. Or a projection of what the next response may look like. Will you be able to handle the response in terms of capacity, in terms of service delivery, and in terms of the timely delivery of your services? Another factor was you have to be able to now invest in the vulnerable components of the system. Now, when we talk about investing in the vulnerable components, you know, you're able to project that these things are vulnerable to the system in order to prevent even an outbreak. First of all, you try by preventing, but when the prevention doesn't work, you now have to look for how to respond to such outbreak. The next factor is, okay, after you were able to try the preventive method, it did not work. The disease was able to come to your domain. You have to now reinforce during this emergency. The next thing is, after responding, there should be an outcome. We are likely to win from the response. Then later on, you have to sit back again, review, look at what your performance index was, what were your shortfalls, so that subsequently you could build on resilience. Now, I've talked about a lot about the healthcare resilience system. Let's be factual. There's no way we can achieve healthcare resilience without achieving laboratory resilience first. This is because at least 70% of the healthcare delivery decisions are based on the laboratory results. So in other words, a major factor in achieving healthcare resilience is an accessibility to a very rapid and reliable laboratory services. So now that brings us to what is a resilient laboratory. Now, a resilient laboratory system could be described as the capacity of the laboratory to also adapt, drift, survive in the face of health system disturbance. Now, this captures the outbreak, and which most times comes in the form of disease outbreak. Now, with specific to the healthcare, what are really our inputs? Now, it's expected that for you to say a laboratory is resilient during the outbreak, it means that laboratory was able to contend with the capacity of work needed for it during that outbreak. Now, after the capacity, you look at the quality of the service. That during that outbreak, the quality of that service was not compromised. And also, lastly, is the timely delivery of these services. Now, let's look at the public health system. The public health system was well looked at by Professor say yesterday. So now we are only going to look at the public health system as it regards to only COVID-19. Now, for the successful detection, characterization, tracing of disease transmission that is essential for the prevention and control of public health events requires an efficient public health laboratory system. Let's get it right. At this point, it's not a laboratory, but a network of the laboratory. In public health, like I earlier stated, a laboratory alone cannot stand to be effective. And this is because they provide high quality data for disease prevention, control, and surveillance. So that tied network is very essential with a harmonized network critical to strengthening laboratory services. Next slide, please. Now, this is what is the structure of the public health laboratory system should look at. I earlier mentioned that the outcome of whatsoever system is dependent to how good the healthcare system of that place was even before the public health system comes to play. You have seen that the first line from the down is the health center laboratories. This is synonymous with what we call the primary health laboratories. The district laboratories is synonymous with our secondary health facilities, laboratories to be specific, and the provincial laboratories. The provincial laboratories here, we're looking at the state public health laboratory, and the regional laboratories, and the reference or national laboratories. In our studies here, we are looking at the NCDC reference laboratory. That was, sorry, let's still go back to that. That was the controlling body of this network. Now, this is what it's supposed to be. But if you look at the pandemic, during the pandemic of COVID-19 in Nigeria, some laboratories, some of this network were escaped. I would like to inform us here that as of the first time of the COVID index, the country had only 5 laboratories that had the capacity to test for COVID-19. Just 5. So that should answer to us how prepared we were actually at the onset of COVID-19. Now, the good news is that the country, as at present, is having more than 100 molecular laboratories that can test for COVID-19. So that is actually a plus now for us. Now, I was looking at how efficient was the network followed in this perspective. No. Now, we didn't have the primary and the secondary laboratory system to be able to cater for this. And one of the major reasons was that they were not well equipped for that. So that was boycotted, and then it now started with the state laboratory, public health laboratory. You know what the outcome was? Of course, the workload was now on the public health laboratories, as against if these 2 laboratories were to be equipped. Now, as we speak till today, we don't have a regional laboratory. But the function of the regional laboratory is still being performed by the national reference laboratory. That at the start until today gave a lot of work to the national. There was a lot of pressure on the national that at the end of the day, they did a good job, no doubt, but so many things that could have been done in other perspectives were not given preference. Next slide, please. So let's look at the rules of the public health laboratories in disease outbreak. Now, the public health lab actually help in disease prevention, control, and surveillance. Public health laboratory help in the preparedness and in response. It helps in health, environmental health and protection, laboratory improvement and regulation, and also in training and education. Most of us are beneficiaries to that. Before the events of COVID-19, some of us even have knowledge on molecular basis of disease, not to talk of COVID, to be specific. But we're privileged to be able to be trained through these laboratory systems that I was actually meant to strengthen laboratories and to give effective response to. Next slide. And let's look at factors affecting the public health laboratory system. Now, we're supposed to be talking about resilience, but in reality, when it comes to Africa and also outbreak, even in the world, there was no resilience. By the definition we actually had there, you realize that there was no country in the world that was able to provide resilient healthcare system during the outbreak. Now, because the outbreak was overwhelming, it overwhelmed every healthcare system. Now, but does it mean that because there was no resilience, we should not use that word? No, it has its own advantages. Now, in as much as we did not achieve that, some people call it a theoretical framework, but also it's an encouraging framework to know that you have a lot of work to meet up in your quest. So some of the factors that actually affect the public health system laboratories in our country was the laboratory system network. Like I earlier stated in that pyramid, we had so many laboratories. Although now the healthcare system, the primary healthcare, are now in use because RDTs has been deployed. But these things came almost after the peak. The RDTs were deployed, were used as a means of diagnosis after the peak of the COVID-19. Maybe if it came much earlier, it could have much impact and lesser impact of workload on the other healthcare laboratory systems. Poorly equipped public health laboratory system. Now I use that word poorly because certain function that the public health laboratories should have been able to perform are still unable to perform that. For instance, characterization. When we talk of characterization, we're looking at sequencing. Now, gene sequencing was a major factor during the COVID era. We had problems with sending samples. I could remember one of the samples I sent actually stayed for more than a month. So it means that if COVID was actually a disease, that the sequencing was actually treatment-based, as in was used as a guide for treatment, then it could have been actually led to a poor prognosis or a poor healthcare delivery timing. Imagine sending a result. These are things that if we had maybe a regional laboratory or even the capacity for sequencing in these laboratories, it could have been something that would have taken 24 hours at most. So this was a major setback too. Now, personnel strength, competency, and training. Even in the healthcare system, without the public health lab, we always complain on the issue of personnel strength. It's no new thing. Our personnel strength are small. You see a system where scientists are being kept to do work of 4 scientists. The facility that should employ 10 will employ 3. So in such a system, there's already a constraint on the workload. And most times in response, what happens in response is that you pull from the healthcare system to augment the strength of the public health laboratory. Quality management system. Yeah, quality management system was also an issue. Now, one of the issues that arise on quality management system was the lack of harmonization of the different kits. You realize that facility A may be using a different kit that has a different protocol and a different definition of positive and negative. So you may have someone complain that I went to Enugu say I'm negative. Or before, maybe subsequently, or maybe previously he was in Akwa Ibom, for instance, and Akwa Ibom declared him positive. And you see him going to Enugu after 5 days. And he said he was declared negative. Yes, that is possible on a scientific basis. That is not even the issue of quality. But you have an issue where someone goes to 2 different laboratories for states that has 2 different laboratories at the same time. And he's been given 2 different results. Sometimes the issue of quality there was because of the interpretiveness of the test kits. So there was not much time for them to harmonize on what was the baseline between positive and negative. So it was now based on only the different kits that arose from this response. Next is supply chain management system. Well, I will give it to NCDC. The supply chain management was good. But in the case of pandemic, you also see that the supply chain management should not be only to the sites that are fighting. It expected that it should be a wholesome approach involving both the state, the partners, and the federal government. Now, what we observed during the pandemic in regards to COVID was that we had most of the healthcare workers coming down from COVID from the healthcare facilities. And one of the major factors was they didn't have a good supply chain management. When it comes to PDP and PPE, most of them were not well equipped. And these are the people on the first line system. So we just have to, maybe subsequently, when such things comes up, we realize that we should give the same preference that we are giving to people at the COVID testing site with people at the front line. They're even at the more risk because they see these patients firsthand, even before making referral to the public health laboratories. Then funding priorities. Funding priorities was a major factor. We had some state, thanks to my state, the issue of funding was not a major thing when it comes to laboratory funding. When it comes to all the things we needed, they gave us. Reason is not being far-fetched. When the political will is right, when there's a political win, the funding of the project will also be sorted for. So for my state, we didn't have this up, though most of the time the meeting we had people complaining of issues as low as light. Molecular is not something you run only when you on your laboratory light, only when you are about to run tests. The reagents there are reagent that requires steady light. So you have some people complaining that they are unable to fund their laboratories because they don't have fuel. So funding to some sites of the laboratories was also a hindrance to delivery of laboratory service during the COVID-19. Next slide, please. Now, okay, I want to make this conclusion. Now, when we look at the resident laboratory system, it can only be accomplished by efficient national laboratory network. That includes a functional public health, both clinical, reference, and also the primary health care laboratories. In addition, let's always remember that if we want to build resilience, we have to look at advanced assessment of the system capacity. Even before the projection of that outbreak, we should be able to invest in that vulnerable component to prevent the occurrence of that outbreak. And also, we should be able to, next slide please, to reinforce the ability to reinforce when all our targets were not met is one of the things we have to look at if we must achieve resilience in the subsequent outbreak. Recommendation. One of our biggest challenges I had mentioned was that till today in the country there's no regional healthcare laboratories in the country. Now these regional healthcare laboratories are essential, like I mentioned, that they have their own function in coordinating the region. This will help reduce the workload that was put on the NCDC National Reference Laboratory during the COVID-19 experience. We also need both the primary and secondary healthcare facilities should be adequately equipped. We don't have to wait for another outbreak for this to be implemented. Funding of laboratories should be prioritized, and existing laboratory place should be maintained. As I speak to you, I said we have more than 100 molecular laboratories, but how many of them will stand the test of time in the next 1 year? The truth is, molecular laboratory is expensive to maintain, and whether we like it or not, whether we believe our politicians or not, the economy of this country is dwindling. So the existing laboratories should be able to be maintained. We have to encourage the government to see the need to maintain these laboratories so that when we have subsequent outbreak, whether you pray for it or not, is a natural occurrence. And when these things happen, we should be able to be on our feet and then stand firm in order to be able to protect the health care of the system. For that is what we are being called to. Thank you for listening.
Your hands together again for my see your for a wonderful lecture. So whether you like it or not, our economy is what? Dwindling. Wahalo. So that was done by Dr. Julie Johnson. Your hands together again for her. Thank you very much, man. She's still here, and of course, we'll entertain one question because of time. If you have a question around this lecture that she just delivered, please, it's time for you to ask that question so she answers the question right now. A question? Thank you.
Good afternoon, all. I want to really appreciate Dr. Julie for the excellent presentation. Please, my question is, in the public health laboratory, are there other professionals aside from the medical laboratory scientists that are qualified to work in the public health laboratory?
Okay, thank you for that question. When you look at the public health laboratory without bias, it depends on the function of that public health laboratory. What is the capacity? Now, you will not say, because one of the major issues we are having in MLS is that we don't even have much specializations. The public health laboratory is such that it's not meant for only MLS. Sorry to, I'm not trying to massage your emotions, but let's face realities. How many MLS are qualified for gene sequencing? Now, the public health laboratory system too depends on under what umbrella was it being formed. We have public health laboratory system most times that are being encouraged to be formed under the Ministry of Health. We may have a public health laboratory that is private. Now, even if you say the regulatory bodies should come in and say it must be only MLS, do we even have enough MLS with such a capacity to fill that place? So these are the factors. The regulatory factors. First of all, it has to be a regulation. That regulation has not been met. And even if the regulation has not been met, we don't have the manpower to fill the space. I hope I've explained that. Thank you.
Thank you very much. So I don't know if we have data on the numbers of certified licensed medical laboratory scientists in the country. Do we have that? Certified licensed medical laboratory scientists in Nigeria. Do we have a data on it? We have, right? Because doctor just said we don't have enough manpower. Probably doctor would have been said that we don't have enough skilled. Yes, I think it's the word skilled, and that's why we're here, to get to understand that there's a gap. You said gene sequencing, right? So there's a gap there. And if there's a public laboratory and they require the expertise of a licensed laboratory scientist, then it should be that we should have those that are qualified to do the job. So if it's for the numbers, I would want to say we have. I think we have. But if it's for the manpower and the skill, maybe. But all thanks to COVID, the molecular thing now is becoming part of who we are. Thank you very much, Doctor. You've done really well. Let's celebrate her once again. Thank you very much. All right, I believe your beach clothes are ready. Food is being served. And after here, we'll be having a pictorial session with the leadership, the NOCs, and every member or participant of this wonderful annual public lecture. So on that note, I would want to say, whilst the food is being served, let's have a closing remark from the NOC chairman. Please, let's welcome MLS. Is it Patrick now? Okay, before that, we'll have an award presentation. And we'll be honoring our wonderful erudite doctor that just finished work here. Please, let's celebrate Dr. Julie Johnson as she comes for our award. Let's celebrate her now. Capacity, young, fresh, wonderful looking. You get why? The future belongs to the younger people. All right. To present this award, let's welcome MLS Prudence Okara. Your hands together for her as she comes.
Award of appreciation presented to Dr. Julie Johnson Epo as guest speaker for your excellent presentation, impartation, and significant contributions in increasing the knowledge base of our members in the 4th annual public health lecture at Uyo, Akwa Ibom State. Thank you so much, ma'am.
Let's celebrate her now. Let's celebrate her now. Capacity everywhere. Thank you very much. We'll be having another one as we plan to wrap up. And of course, this will be presented by our 001 National. No other person but MLS. Huda Emmanuel. Your hands together for our 001 as he comes to present this award to this is a capacity thing. No? The nominal young man that has done very well in his stay as the YMLS chairman of River State. Please, let's present this award to Anthony Austin Uzochi. And to receive this award, we'll be having the vice president, or vice chairman rather, the vice chairman, Precious Kekile, for this award. Your hands together as he makes his way. Let's celebrate him now. Thank you very much, Mr. President.
All right, thank you so much. Before I present this award, this is the second edition of this particular award, YMLS Best Branch Award. And this was instituted during this administration in a bid to encourage our branches, states across the Federation. Leading at this level in the profession is a Herculean task, a very challenging one. Understanding that there is paucity of funds or even no funds, but yet there are a lot of expectations, a lot of challenges that needs to be taken care of, a lot of issues that needs to be resolved. And I really must say that we have states that have distinguished themselves in giving effective and true leadership to their members in their various states. And unfortunately, or fortunately, we can only award one. But I will just quickly mention 5. The last time we had this, we presented 5 states that was made public on social media, and from there we were able to get 1. But this time we just went straight. So we did not publicize the other states that did well. So we have Bayelsa, Ondo State, Osun State, Abuja, and also Kano. They did marvelously well. I must give it to them. And River State. But of course, there will always be a what? There will always be a what? A winner. And we don't just give award based now, it has to be merited. And I don't have to start listing what they have done. What I'm going to do, I will meet the media team so that they can put on the social media, they can publicize the achievements of Rivers. Just not up to a year, they've been able to do 6 months or so. They've been able to do a lot, even more than states that have stayed for more than 2 years. And the little we can give, the token we can give, is to give them this beautiful award to encourage them to do more. And so please, I would want us to rise and give a round of applause for YMLSF Rivers State Branch. Let us rise and do that as a sign of honor, as a sign of respect to them. So thank you so much. So on behalf of YMLSF National Leadership, we present the award of the YMLSF Branch Award to YMLSF Rivers State, ably led by MLS Anthony Augustine Uzochi. Congratulations. Please, can I have all members of the National ESCO to please come forward? Rivers, all members of National ESCO first, please come forward. So Rivers, if you are wise enough, just come and snap before they come.
Okay, you don't like big hands. Are you serious? There is one that I saw that the hand is like this. Where is the guy now? Where is the guy?
National ESCO, please, I think they are outside. Where are they? Wisdom, please call Jegede and the rest of them outside.
Please, all members of the National ESCOs, if you're outside and you're hearing this wonderful, sweet voice of mine, please make your way inside. All right. So, congratulations once again. Let's have your hands together for them as they make their way. We're going to celebrate grace now. Thank you. That is a good one right there.
Before the vote of thanks, we are moving to the beach. I don't know if it's everybody that is going, so that we know what we have on ground. If you are going to the beach, please can you just raise your hand up? I know all you CTH interns came here for the beach. Raise your hand. So if you are going to the beach, raise your hand up. Okay. So we already have a bus and we have some cars outside that will be conveying those that have indicated interest to the beach. So immediately after this, we only give 20 minutes. 20 minutes. Immediately it is 20 minutes after 3. We are not waiting for anybody. We move. All right? Thank you.
Abigima na bigima. Abigima na bigima. E no dey for size o. Abigima na bigima. Thank you very much, ladies and gentlemen. It was a wonderful experience with you, and I'm your humble servant, and I'm a scientist, and I'm a good man. My name is Mr. Should I say scientist? May it make sense. My name is Scientist Ekripo Erens Spiff. Your hands together for me once again. And not try. You should clap for me now. Oh, what's you? Okay, you're eating. It's all right. All right, at this point, we'll be having the closing remark and the vote of thanks from the NOC chairman. And of course, he will be conveying us with the leadership to the beach. So get yourself ready. Get your clothes. Get your bikinis. Get your bomb shirts. Play with sand. No go carry eczema, sha. So let us have the closing and vote of thanks from our own brother, Capacity Joe Great. Your hands together as Joe Great comes for the closing remark and vote of thanks. Together. Let's clap for him now. Your hands together. About say my food day.
Please, a round of applause for our MC, please. Please, a round of applause for him. I must confess, he did a very fantastic job. I know that he did this for free for YMLSF, but I know the president will not leave him for free. So he has done a good job. Yeah, on behalf of the national president and the leadership of YMLSF, I want to use the opportunity to say a big thank you to all of you for participating in this year's annual public health lecture. This is the 4th series, and I believe that by next year, the 5th series, God will keep all of us in good health and mind to be part of it, either physically or virtually, because I know many of us, we might contribute to the brain drain by next year's public health lecture. If you are for that brain drain, say I. If you want to stay in Nigeria, say kneel. The kneel have it. So I want to also use the opportunity. So I want to also use the opportunity to thank our sponsors. Okay. We thank all our sponsors for your contributions. We thank you very much from AMSIN, MLSCN, and all our individual sponsors. Also, for those who registered for this conference, on or before Tuesday, you're going to get all the slides and your certificates of participation for those who registered for CPD purposes. Please bear with us. Between now and Tuesday, you will get it through your email. Finally, please, after the closing prayer, we want all of us to, I think the picture will be outside or here, okay, to come over to the stage. We'll take picture for archive purposes. Without further words, I want to say thank you very much, and may God grant all of us safe journey and grant us wonderful jobs as we progress in our career. So we say goodbye.
Thank you, Joe. Great. Hands together for him again. And now let me welcome MLS, my friend and my very good friend. Please, let's celebrate MLS Adindu Victor for a closing prayer. Your hands together for him as he comes for a closing prayer immediately.
Please, if you are ready for the beach movement, just stay outside. Why I give 20 minutes is for those that stay. If you know your hotel is far, don't go. We will leave you. To be very sincere with you, 20 minutes after 3, we are out of this place. 20 minutes after 3. So if you have people who are where they are, and they are going for this beach movement, tell them 20 minutes past 3, we are off from here. Thank you. Then if you are ready, just stay behind and wait for.
All right, for the closing prayer, MLS Adindu Victor.
Let's close our eyes. Gracious God, we thank you for this day. We thank you for the opportunity you've given unto us. We thank you for the successful public lecture. Father Lord, we pray, O Lord, that as we go back to our destination, you go with us in the name of Jesus. Father, may your grace go with us. May your love continue to be with us. Father, whatsoever we desire, O Lord, may you give it unto us. In Jesus' name we pray. Amen.
Thank you very much. All right, for the pictures and for the pictorials, please, all the ESCOs of this wonderful forum, national and states, should be on the stage, whilst every participant should also join them for our picture session. On that note, I will leave you in the hands of our wonderful DJ to warm us and warm us and warm us. Once again, Akwa Ibom, Dakada, God bless you. DJ. DJ.
All right, go.
to flex my love, I want to impress, and I want to carry my love to a place she loves. I want to impress, and I want to carry my love to a place she loves. My body calling, and your body big. Loving you, they make me forget, say I get broken. By the end of the night, enter battle, tension. I want to flex my love, I want to press, and I want to carry my love with place she loves. I want to press, and I want to carry my love with place she loves. You don't want to find my trouble.
Get too much feeling for this club, and then no one let me go. Then no one let me go. Then no one let me go. I'm looking fire, carry cash, and I must to carry go. I must to carry go. I must to carry go. My girl did the waka waka, left and right with the biggie baka. Instagram don't finish data. Big nash, me I must to naka. My head, my neck, my waist, but I still want that. I want that. My head, my neck, my waist, but I still want that. I want that. My head, my neck, my waist.
Wake up. Tera, go get the moolah. Wake up. Bonito kala konya la wadila. Don't walk it, don't try. You supposed to be jai. You look come person, my town person we don't mind. When I land softly on the sofa floor. Sofa so good, only by jump. Let me see you, oh lo lo. Let me see you, oh lo. Bukao, let me bukao. Let me see you, the buka, oh lo. Let me see you, oh lo. Bukao, let me bukao. Let me see you, the buka, oh lo. Let me see you, oh lo. Bukao, let me bukao. Let me see you, the buka, oh lo. Let me see you, oh lo. Bukao, let me bukao. Let me see you, the buka, better, go get the dollar. Wake up. Okola, la odila. Don't walk, don't try. Supposed to be high. Kilo kan chef water. They see all your mind. When I land softly on a sofa floor. Sofa so good, only by jump. Let me see you, oh lo. Let me see you, oh lo. Bukao, let me bukao. Let me see you, the buka, oh lo. Let me see you, oh lo. Bukao, let me bukao. Let me see you, the buka, oh lo. Let me see you, oh lo. Bukao, let me bukao. Let me see you, the buka, oh lo. Let me see you, oh lo. Bukao, let me see you, bukao. Let me see you, oh.
More music from SolarPlay.com.
Malako Ibom! Ole Bukama, hey, Ole Kuibon, Ole Bukama, Ole Kuibon, hey, Alugulugu, yeah, Babulu, yeah, Babulu, Lugu, yeah, Babulu, yeah, Babulu, Lugu, yeah, Babulu, yeah, Babulu, Lugu, yeah, Babulu, hey, yeah, Babulu, Ingangela, ungayithinta yena intayibona, ewele bot, ingangela, ungayithinta yena intayibona, wemaluma, ingangela, ungayithinta yena intayibona, ewele bot, ingangela, ungayithinta yena intayibona,
Open the fire, play the bed to let them know. No finish.